الحالتين يقدم. اذا الفي اي بي قدم لك البزنس كارد تقدر تقدم له، او اذا طلب منك البزنس كارد تعطيه. اما انك كل ما شفت وزير كل ما شفت مسؤول تعطيه بزنس كارد، ترى بيشيله وبيعطيك سكرتير، ما يشيل، هو ما بياخذ يحطه في جيبه، فيفضل انك ما تعطيه. ايضا يا اخواني بزنس كارد لازم تتعامل معه باحترام. كيف يعني باحترام؟ ان اذا في خطا، في معلومات خاطئه، يفضل انك تستبدل البزنس كارد. يعني في ناس يعطيك البزنس كارد تطلع بعدين هذا الرقم قديم، هذا الايميل قديم، يشطب على بطاقته. هذا ايضا اسلوب غير مهني غير احترافي، فيفضل ان يتم استبدال البزنس كارد. هذا حسابي في سناب شات، حق اللي يبغى ممكن تصورونه، وبنفس الاسم المرزوقي ام دي، نفس الاسم هذا في تويتر في انستغرام دائما المرزوقي ام دي. فاللي حاب يضيف ممكن الان يصور و براحتكم تضيفون. وان شاء الله المواضيع اللي تحبونها ممكن يعني ترسلوا لنا اياها، وان شاء الله نتكلم عنها. بعض الامور نتكلم اللي نقدر. طبعا موضوع السناب شات مو مثل دوره مثل هنا بتكلم بهالتفاصيل، لا، لكن بالنسبه للجانب المظلم اعتقد موجود رابط وممكن انزله او اتكلم فيه. تامرون امر يا وزاره الصحه. نحن نقول نبغى نرد قطره من بحر فضلكم علينا، نبغى نرد قطره من بحر فضلكم علينا. الله يوفقكم ويحفظكم، وما بنقدر. طيب نتكلم عن اتيكيت الاجتماعات. بنتكلم بشكل سريع، ما بتكلم عن اداره اجتماعات، بنتكلم عن ذوقيات الاجتماعات. بنتكلم، جزاك الله خير دكتوره، الله يحفظك. بنتكلم عن ذوقيات داخل الاجتماع، لان في شيء اسمه اداره اجتماعات. اداره اجتماعات الله يحفظكم، ما بقدر ارد على الجميع، على راسي على راسي كلكم. يعني سامحوني اذا ما رديت، ان انا موجود الان في الرياض، ولكن يعلم الله اللي دائما ادعوه، اللهم احفظ المملكه العربيه السعوديه ملكا وحكومه وشعبا. خيركم سابق مغرقنا، الله يحفظكم. ومن كذا نحن نقدم ان يعني ودنا السعوديه اليوم مقبله. اخوان السعوديه اليوم انتم تحضرون اجتماعات دوليه. السعوديه اليوم عضو في جي 20 اليوم. اللي يجي السعوديه يجتمع، يعني هذه ارض الحرمين، هذه السعوديه ارض الحرمين. لما ندخل اجتماعات نراويهم. الان احنا قاعدين ندرب المطارات، 27 مطار كلهم بيتدربون كيف يستقبلون الفي اي بي، كيف مبتسمين مدربين. خلاص خلصنا الرياض، نحن الان موجودين في جده، بنوقف رمضان وبعدين بنكمل، وان شاء الله عندنا اكثر من وزاره. خلاص السعوديه اليوم عندها فيراري، راليات، سباق خيول الاغلى في العالم، جولف، كل الجمهور قاعدين ويحتك فيكم. والسعوديه اليوم متقدمه جدا. مثلا وزاره الصحه السعوديه وين اليوم بيون العالم بس يستفيدون من تجربتهم، يبون يتعلمون كيف نسمع في الاجتماعات، شو آداب الاجتماع، نخليهم ما ينسون. اليوم يا اخواني السعوديه سعوديه عظمى. اليوم يا اخواني سيدي خادم الحرمين الشريفين وولي عهد الامين قاعدين يصرفون ملايين الملايين عشان يجيبون هذه الفئه من الجمهور الى السعوديه. هذا ما يجون، هذا مش سهل تجيبهم، يعملوا لهم بطولات في الجولف عشان يوصلونهم للسعوديه. حرام مئات الملايين تنصرف عشان يوصل. بعدين يجون عندنا، نحن لازم نكمل الصوره، ونراويهم من السعودي مدرب، السعودي بثوبه وبغترته وعقاله وطرحتها وعبايتها، تمثل التعامل معك وفق اعلى معيار في الاتيكيت والبروتوكول. نعم نراويهم من الهويه السعوديه، الثقافه السعوديه، الفكر دولي. من كذا دوراتنا احنا اسمها الاتيكيت الدولي، الاتيكيت والبروتوكول الدولي. طيب فخلينا نتطرق للاجتماعات. بالنسبه لكم مهم جدا جدا، خاصه في اداره انا جيت اجتمعت معها. اعتقد اداره الاتصال الدولي او حاجه، هذه الاداره باسرع وقت مفروض يحضرون دورات، ياخذون كيف يلبسون بدله، الوان البدله كيف يختارونها، طول الكرفته المفروض وين تكون، متى الازرار كيف يتعاملون، متى نغلق الزر اللي فوق، متى اللي تحت، متى اللي في الوسط، كيف كل هذه الاشياء مفروض انه دوره. كيف المصافحه، كيف البزنس كارد، كيف اعرف اثنين على بعض، كيف احضر اجتماع، شو الفرق بين المدح والاعجاب. ما اعبر عن اعجابي احد لكن امدح اي احد. هذه كل النقاط محتاجة إلى دورات. كيف توقيع الاتفاقيات، وين علم السعودية، كيف الأسبقية بين الوزراء في متحدة، في جامعة الدول العربية، في الأمانة عامة لمجلس التعاون. أنا حطيت سؤال أقول الآن لو يوم 2 وزراء عند معالي الوزير، جاكم وزير إماراتي ووزير فرنسي وأنت ماسك، كيف تحددون؟ مين يجلس على يمينه، مين على شماله؟ السعودية داخلة في اتفاقية مثل هذه، هل تعرف أنت؟ هل تعرف كيف توزيع الضيوف في الاجتماعات؟ مع الوزير وين يجلس؟ مين على اليمين؟ هو عنده نايبين، طيب اي نايب على اليمين، اي نايب على اليسار؟ طيب عنده الوكلاء كم؟ شفت ما شاء الله هيكل الوزاره الوكلاء كثيرين، طيب اي وكيل يجي هنا؟ هذه كلها مفروض فيها دوره ونضبطها، وعلى اساس بنجتمع مع العالم نبين مدى احترافيتنا في التعامل. طيب، فاذا انا راح اتطرق بالاجتماع كل شيء سطحي، احاول اعطيه شوي شوي لان اشوف الوقت بدا يروح. طيب خلينا ناخذ شوي اتيكيت الاجتماعات. ناخذ اتيكيت. اول حاجه يا اخواني، اذا عندك اجتماع في وزاره الصحه، انا بعطي شيء يفيد الموجودين. انت عندك اجتماع في وزاره الصحه الجهه بتي، ارجوك اترجاك قبل الاجتماع ادخل في قاعه اجتماعات، تاكد هل القاعه جاهزه؟ هل التكييف يعمل صح؟ هل الاضاءه موجوده؟ مو يجون الضيوف ونتفاجئ مكيف ما يشتغل، بروجيكتور ما يشتغل، والضيوف مخبرين ان بيعرضون حاجه. والله انا اتالم لان المملكه توفر كل شيء، والله التقصير من الشباب، من الموظفين. ولا الحكومه موفره بدل البروجيكتور في 10 في المستودعات، ويون الضيوف والبروجيكتور مو شغال. ايضا تاكد هل فليب شارت فاضي؟ يمكن كانوا يناقشون الوكلاء موضوع سري، يمكن كان متكلمين شيء عن، واحيانا ندخل اجتماع كلام مكتوب كان المفروض ما نشوف. لا يا اخوان، ادخل تاكد في اوراق، اطلب امور سريه. قاعدين يناقشون موضوع جائحه، قاعدين يناقشون موضوع ميزانيه، قاعدين يناقشون مثلا مواضيع حساسه عن فايزر وعن نوع ثاني، انه والله خلونا نسوي السعوديين بنفسهم اول شيء. في كل شيء وارد كل شيء. فعلى الاقل يشيل الاشياء ما يشون. تاكد من الدفاتر اللي موجوده ما في كلام مكتوب. كم مره رحنا اجتماعات نشوف استكانات الشاي مال الاجتماع اللي قبل، مال امس بالليل، امس مجتمعين ما حد شاي، صبح جو محطوط، تقول يا مال امس شاي بارد. يا اخوان هاي مسؤوليتك تتاخر. هذا واحد. رقم اثنين، على الاقل اذا كان الاجتماع مجدول، اذا كان مجدول مش من الاجتماعات الطارئه، اجتماعات طارئه الان ممكن سعاده الوكيل الان ممكن يطلبكم اجتماع طارئ، ما هذا ما في. نحن نتكلم الاجتماعات المجدوله. الاجتماعات المجدوله يومين قبل ترسل جدول اعمال الاجتماع اللي بتجون، لازم يعرف شو بتناقش، لازم ترسل له يومين قبل. رقم ثلاثه يا اخواني، خليني اعطيكم حاجه جديده، يمكن اول مره تسمعون، هي مو اجباريه لكن خليني اعطيكم لان بتاخذون دوره. هاي احنا نعطيها لما تاخذ عليها الشهاده. شفت الكرسي هذا؟ شوف، هذا كرسي الجلوس. كثير ناس ما يعرفون الان هذا يمين، هذا ايد اليمين، هذا الشمال. هل انت في الاجتماعات المفروض تدخل من اليمين ام من الشمال؟ لا، الصح في الاتيكيت نشوف الكرسي اخليه على يمين، الكرسي اللي بجلس عليه امسكه بايد اليمين اسحبه وادخل من هنا، شوف، واجلس. ليش دخلت من هنا؟ هي عمليه تنظيم. اللي بيدخل من هنا بيجلس على الكرسي اللي على يمينه، انا دخلت من هنا وجلست على هذا، الكرسي اللي جنبي بيدخل من. هي تنظيم عشان ما في اثنين يضربون في بعض. وش معنى خلي على اليمين؟ لان معظم الناس مركز القوه عندهم عمليه القوه عندهم في اليمين عشان عمليه سحب الكرسي. هذه معلومه يعني مشيتها عاده في المحاضرات، ما نقولها في الدورات لان فيها شهاده ولازم يكون صح فاهم كل شيء، او هاي الدوره ياخذونها وزراء عشان يطلعون برا، لكن نحن نعطي الجميع. طيب، هذا واحد. رقم اثنين اخواني، ممكن تاخذ معك القلم، ما في تاخير في الاجتماع، لما تكون واصل يعني. شوف، هذا نحن اليوم في اجتماع الان، يعني كم وصل عدد المشاركين؟ ما شاء الله 280. مفروض انك تدخل قبل ما يبدا الاجتماع. يعني نحن بدانا وكان يمكن في حدود 80، 200 دخلوا متاخرين. لا، مفروض انك انت تدخل قبل بدايه الاجتماع، ما تتاخر عن الاجتماع، غير لائق انك توصل بالاجتماع بادي. ايضا قلم، تقدر تستخدم قلم العادي اللي موجود في القاعه، احيانا في قلم رصاص، احيانا في قلم حبر. ممكن تحب تستخدم قلم فاخر، ممكن. في ناس يقول لا انا احب اجيب معي قلم فاخر، ما في مانع، تقدر تجيب قلم فاخر. لكن غير مرغوب ان تجيب لي قلم غريب، قلم عليه بابا سنفور فوق، شو، او دعايه لشركه، او شيء يولع، او يعني هذول الاشياء قلب عليه. لا، هذه اشياء غير مرغوبه في بزنس، في اجتماعات العمل. ايضا اثناء الاجتماع غير مرغوب انك تنشغل بجوالك. يعني لا ترد، المفروض الجوال ما تدخلونه اصلا، المفروض الجوال ما تدخلونه، ما تدخله معك، بدون جوال تدخل. فاذا دخلت على الاقل نخلي في جيبك. وغير مرغوب انك تفتح ترد على رسائل او تنشغل. حتى في بعض الناس متعودين ان يكتبون في التليفون، يعني يكتب الملاحظات في نفس التليفون. اذا بتكتب التليفون في بدايه الاجتماع نوه ليش؟ يعني انتم تخيلوا انا الان جالس باجتماع تليفوني معي وانا قاعد اكتب ملاحظات، الناس ما يدرون، يفكرون انا العب تليفوني. فاذا بكتب في اي نوع من التابلت، فممكن اول ما اجي اقول اسمحوا لي انا ترى بكتب الملاحظات على جوالي. فشوف اعطيت ايحاء ان لما بيشوفوني وانا اكتب يعرفون اني انا اسجل ملاحظات مش مشغول بالتليفون. غير مرغوب انك ترد على المكالمات في القاعه. ايضا يا اخواني، طريقه الجلوس هي هذه الطريقه الصحيحه، اني اجلس واليد تكون على الطاوله فاتقدم، ما اسند ظهري. لا، شوف دائما في الاجتماعات يفضل انك تكون متقدم، هذا تعطي اهتمام للموجودين في الاجتماع. وبعدين اقل حركه فينا، هذا اللي يستندون تشوف يحرك الكرسي يمين يسار. طبعا ما يستوي ان انا اخلع حذائي، اخلع نعال، عيب. في ناس طبعا يتربع فوق، لا ما في، سامحوني، ما في حد يتربع. ايه يلعب بالسبحه، ها، يلعب سبحه، او احيانا تشوف مشغول طلع له توقيع جديد، يرسم، مسوي له ورده، مسوي له فراشه، هيكل عظمي. هذه كل سلوكيات غير مرغوبه، ما لها علاقه بالاخرين. اولا انت ما تقدم نفسك للعالم بالشكل الصحيح. الشيء الثاني انك تسيء وتقلل من احترام الاخرين، والتقليل ناتج انك على نفسك. انا ما لي علاقه مين موجود في، حتى لو كانوا زملائي، انا اقدم محمد دائما باجمل صوره، بابهى محمد دائما يدخل في اي مكان بارقى صوره. هذا هو الصح، انك تفكر في نفسك. ايضا يا اخواني لغه الاجتماع، يعني مثلا انتم مجتمعين مع مثلا وفد كوري، وفد سعودي، وفد كوري، عاده لغه الحوار بتكون لغه انجليزيه. فاذا حتى السعوديين ترى يكلمون بعض بالانجليزي، ما يستوي ان نشفر. يعني كوريين جالسين نتكلم معهم انجليزي، فجاه نقلب عربي بعدين نرجع نكلمهم، لا هذا فيه تشفير. فخلاص لغه القاعه، لغه الاجتماع تتحول الى لغه انجليزيه. حتى الوفد السعودي اذا بيتكلم بعض يتكلم الانجليزي، والوفد الكوري اذا بيتكلم بعض المفروض ان نتكلم بالانجليزي. ايضا من الاخطاء اللي موجوده في اجتماعاتنا ان يجيبون اكل على طاوله اجتماع، هذا غلط. حضرت اجتماع ما شاء الله فطاير جبن، والسندويت كانوا جايبين من لامولا، وجايبين من ما ادري حوكه ما ادري ايش، كل السندويتشات صميني. وهذاك يقول لي جرب جرب دكتور، جرب اللبنه بالزعتر ممتاز. وهذا يقول لا جرب، جيبوا لي شاي دكتور، يقول كرك. هذا اجتماع بالله عليك، والله هذا اجتماع. لا وبعدين الحبيب ماكل ياكل يكلمك في زعتر يبي يصيده. امم بعدين بتشوف مرحله هو يصيده خلاص صادع، الحين بيتخلص منه. مرت عليكم صح، مرت. فاذا المفروض انه ما في اكل ممكن يكون اشياء خفيفه، مثلا حاطين آه، حلويات او شيء بسيط، او انه يكون في على الجنب في اكل. ان المجتمعين ممكن يوم قبل الاجتماع اللي حاب ياكل، او بعد الاجتماع ايضا ياكلون. بس اثناء الاجتماع شغال، والله انا لاحظت الحبيب يقول قرب تفضل تفضل، ورئيس الاجتماع يقول لهم يا شباب خلوكم معي، يا هذا مجتمع ضيوف عندنا. بعدين العامل داخل يوزع شاي والاجتماع جاري، المفروض ما يسمع العامل، المفروض ما يسمع الاجتماع شو اللي حاصل، وين درجة السرية، وين. ممكن ماي، ممكن انواع من الماي، ماي غازي، ماي ممكن تحطون مكسرات. يعني في ممكن حلاوه اللي يحطونه في الفنادق اللي يغير طعم فمه. بس انا قصدي تجيبون سندويشات، انواع من الساندويتش خبز هذا وانواع من العصير. لا ما يقدر، هو مو شغله. ممكن تجيبون بس خلوه على الجنب. يعني مثلا اجتماع طويل ساعه، بعدين نكسر اجتماع، عندنا بريك، في البريك مثل المؤتمرات ناكل بعدين نرجع. او انه بعد ما يخلصون الاجتماع براحتهم ياكلون. اما داخل اجتماع اكل ولا وجاي لي خط هني شارب بيمدو احمر مسوي لي، هذا كله غير لائق. انا اشوف اسئله كثير قاعد تجي بس ما ملحق اني اشوفها او اقراها. خليني القي نظره، خاف ان في طلب من الكنترول وانا مو منتبه. مش كنا الكنترول متواصلين مع المدام، وانا مدام مو موجوده معي الان في هاي اللحظه. دعم رسمي، خليني اقرا رسائلكم. ما في رسائل. سامحوني مو قادر اقرا، كميه رسائل والله كبيره، اعتذر منكم. طيب، هو اذا في شيء اكيد المدام راح ترسل لي على الخاص، اذا في ملاحظات من كنترول الى الان ما جاني شيء منها. فاذا في اكيد راح ترسل لي اذا في ملاحظات او شيء. ما في، اكيد جت تقول ما في شيء. ف طيب. آه... ما راح اتكلم عن توزيع الضيوف، خلينا نتكلم جزء منه عن اتيكيت بين الزملاء. وهذا ايضا كان من احدى الاشياء اللي كانت مطلوبه في تغريده الدكتوره، اللي كانت ملاحظات تحت. خلينا نتكلم عنها. اتيكيت بين الزملاء، ناس يعتقدون ان الذوق فقط يكون مع الغرباء، والقريب لا. بالمناسبه الاقرب لك اكثر محتاجين منك ذوق ومراعاه مشاعرهم. كل ما تقربوا اكثر محتاجين. خلينا نتكلم شوي عن الاتيكيت بين الزملاء، بعض نقاط بسيطه بس نتطرق لها. طيب، واحد، التصرف مع الزملاء. اخواني، حسن التصرف مع الاخرين في العمل يعني انك تكون متعاون وايجابي، لان ذلك يخلق نوع مناخ مفعم بالحيويه. ايش الاشياء؟ خلينا نشوف الان بين الزملاء. واحد، احترم خصوصيه الاخرين وعدم التدخل في المساحه الخاصه والشخصيه للزملاء. مثلا كيف يعني؟ كل انسان لازم يحترم خصوصيه زميله وما يتدخل فيه. يعني مثلا يجيك موظف او موظفه تقول حق زميلاتها او تقول زميل، واحده مثلا طلع شعرها، يقول عفوا ترى انت مطلع شعرك ما يجوز. وانت ايش لك؟ في حد عينك في وزاره الصحه قال لك انت واعظ؟ في حد قال لك هل كلفوك وزاره انك واعظ؟ ما يجوز. ليش تطلع شعرك؟ مو شغلك. مو شغلك تقولين هذا ليش ما يطلع شعرها، انت ليش حاطه ميك اب، وانت ليش ما ادري ما تصبغ لحيتك، صليت ليش ما صليتوا يا جماعه اذن يا اخي. في حد قال لك انت في وزاره الصحه واعظ؟ ما لك علاقه بالاخرين، ما لك علاقه بخصوصيتهم. مثلا دوامكم في الوزاره، فلنفترض انا ما اعرف الساعه كم يبدا، بنقول مثلا دوام يبدا الساعه 8، في واحد من الموظفين يجي الساعه 7 او 6. الزملاء يقول انت ليش تيجي من وقت؟ يا اخي انت ايش لك كيفه؟ ان شاء الله بيجي الساعه 5. هل مخالف نظام الوزاره؟ اي مخالف. الجهات المسؤوله بتكلمه، انت ايش لك؟ يقول له ليش ما تطلع اول ما يقولوا لك ينتهي الدوام انت ما تطلع؟ ليش تجلس الساعه 4؟ ان شاء الله يجلس الساعه 5، شو المشكله؟ طب انت ليش متضايق؟ يا جماعه هذه خصوصيه. كل انسان له خصوصيه، انه متعود انه يتعامل بطريقه معينه. لا، في ناس والله يتدخلون في المشروب، صباح جاي يشرب. مره كنت موجود في مكان ما، مش وزاره الصحه، في مكان ما، واحد قدامه حليب مراعي، صباح حليب مراعي، وانا جالس. دخل عليه الزميله قال له لمين هذا حليب؟ قال لي انا. قال بالله عليك حد يشرب صباح حليب بارد؟ قال لي انا اشرب حليب بارد. قال والله ما عندك سالفه. قال لي ليه؟ قال الصباح ناس تشرب قهوه مو حليب. يا اخي انت تحب قهوه، انا ما احب قهوه، انا احب اشرب حليب، شو المشكله يعني؟ لا لا، لازم تكون مثلي ولا انت غلط. العالم خطا دام انه مثلي انا يتصرف. ما لك علاقه فيه، بيجي من وقت. او اقبح من هذا، اقول واحد يقول حق وحده، او وحده يقول حق وحده انت دائما حامل؟ انت ايش لك؟ هذا سؤال وايد حساس وايد شخصي. انت دائما حامل؟ او انت ليش كذا وانت، او ليه ما تزوجتي؟ تزوجتي ليه ما تزوجتي؟ وايد سؤال يبين مدى ما ابغى استخدم كلمات بايخه، ولكن بايخ جدا. ايضا يا اخواني، احترم وجهه نظر الاخرين وتجنب فرض ارائك عليهم، فلكل شخص اسلوب حياته. كل واحد عنده اسلوب، اسلوب في يكتب تقارير، له اسلوب كيف مثلا يسمع كلام مديره، في اسلوب ما اتدخل، ليه تعمل كذا، انت ليه تعمل كذا، وتوقف، ليه لابس لي هاللون، انت ليش تلبس احمر، انت ليه تلبسين عبايه، ما له داعي، ليه لابس شماغ، في المكتب شيل يا اخي، ما يبغى يشيل، هو يبغى يداوم بشماغ وعقال، انت ايش لك، ايش عورك، ايش عورك اذا هو لابس. الان نحن طالعين من جائحه، في ناس يدخلون الوزاره لابسين كمام، في المكتب كمام، برا لابس كمام، يقول انت ليش لابس كمام؟ يقول له خلاص مو لازم. طب هو حاب وانت ايش لك؟ كيف هو حاب؟ في ناس تعقمون بين فتره ثانيه، يقول له بسك، ذبحت نفسك، موت الميكروبات. انا ممكن اعرف ايش يعورك انت لما هو يتعقم؟ ايش يعورك؟ ايش وجعك؟ يا اخي ان شاء الله بيشرب التعقيم. كيف حياته، هو متعود بهذا النظام انه بيعقم، يقول لا لا تعقم يخرب لك ايدك، لا لا تسوي كذا بيسوي كذا، لا اترك الاخرين يمشون في حالهم. هذا واحد. ايضا يا اخواني، ان ممكن انت تروح مكتب زميلك، اذا مريت على مكتب زميلك مش من الذوق انك تجلس على كرسيه مهما كانت قوه علاقتكم، تجلس على الكرسي ماله، او تفتح درجه، او تشوف الكمبيوتر ايش مكتوب مخالف للذوق العام، مهما كانت قوه علاقتكم، ان شاء الله انتم اخوان ودامون في الوزاره، غير لائق اني اروح وافتح درج زميلي، اني اروح، لا والاقبح منه اني يشيل تليفونه، تليفون يرن يقول مين يشوف. لا تفكرون هذه والله يقول لك طايحه الميانه، لا هذا مش ميانه، هذه قله ذوق وقله ادب وقله مراعاه للاخرين. نحن تعودنا ان كثير ندخل في خصوصيه بعض، واذا السعوديه اليوم على رؤيه 2030 ان نحن بننافس ان نكون من افضل دول العالم، ما بنقدر الا نصلح من الداخل. اذا الموظف مو مرتاح بيتعب في العطاء، ما يقدر يعطي، فما لي علاقه، ما اقدر شيء. شوف، زميله يتكلم تليفون، او مدير يتكلم تليفون، ما تدخل عليه، ما يشتي تدخل على المدير يتكلم تليفون، ما يشتي تدخل على زميلك ويتكلم تليفون. تعرف انا امس شفت منظر كيف؟ مدير يتكلم تليفون، انا جالس ويكتب، يعطونا ملاحظات، دخل عليه واحد من الموظفين، مدير يتكلم يقول له المدير ما فاهم انت شو تقول، ترى مسكين يتكلم مكالمه وقاعد يكتب ملاحظات، وهذا جاي لنا شو شو ما يفهم عليك. توقيع المدير مسؤوليه. بعدين يا اخي انت ما تشوف عنده مكالمه ويكتب وعنده ناس بهاي الدرجه؟ ابالغ؟ توقعون ابالغ ولا هذا واقع موجود؟ لا، بمجرد ما تشوف زميلي يتكلم تليفون ما اروح له، ما اروح له. حتى الزميلي، حتى اقرب صديق، زوجتي، انا احيانا اكون جاي بسياره والله اني انزل مطعم مثلا مكان اجيب غراض، اي اشوف اتكلم تليفون، اتعمد اني اتباطني، ما ادخل، ما اتكلم امها في موضوع خاص. احيانا هي تشتد تقول لي تعال، يعني ما في شيء خاص، يمكن تكلم امها، يمكن تكلم بين السيدات كلام خاص، امراض نسائيه، اشياء، فهي شافتني نزلت وتبي تقول لها، اذا هاي زوجتي فما بالي بزميلي، وارد تتكلم امها في موضوع خاص، عندها مشكله نسائيه وتسال امها، تستحي قدام زوجها. قلنا لا والله، يعني نحن بتقول لي والله بين الزوج والزوجه مراعاه، طبعا في مراعاه، طبعا. اذا انا براعي اي انثى، هي اولى وحده راعيها. اراعي انثى في الدوام وراعي الانثى في برا وداخل البيت ما راعيها؟ لا، هذا غلط. آم، ايضا اخواني، احترم المسمى الوظيفي والاقدميه، وافهم الواجبات تجاه الاعلى والادنى، ان في موظفين اقدم، في موظفين جدد، هذا اقدم مني ونحن نفس الدرجه، لكن دائما اقدم يعتبر سينيور عليك، او يبين له لا انتم دقه قديمه. بعدين انا ما اتفق مع موظف، طب قول له وجهه نظرك. في ناس ما يقولوا وجهه نظر، لا لا، يطعنون فيه، يقول انت وين عايش؟ انت من وين طالع؟ تحت تجريح الشخصي هذا. طب انت مش موافق رايه، يعطيك راي، ناقش رايه، ايش لك تقول له من وين جاي؟ انت وين عايش؟ ترك النقطه، دخل في خصوصيته، في انسانه، في يهين كرامه انسان. ايش لك من وين جاي؟ ايش لك وين عايش؟ تقول انت وين، انت صاحي؟ مع انه هو اذا قالوا لك كلمه، لا هذا طعن فيني، لا انا لا احد يقول لي، بس انا يقول لا تفهم ومو قصدي. تضحكون ها؟ تعامل باحترام ولباقة مع جميع الموظفين والعاملين بالمؤسسة بصرف النظر عن طبيعة وظائفهم أو درجاتهم الوظيفية. اليوم يا إخواني أنت لك فرق بين إنسانيتك ودورك. شوف، أنا إنسان ولكن دوري مدرب. أنت إنسان مثلي ولكن دورك في موظف وزارة الصحة. في بيننا مثلا إنسان ولكن دوره طبيب يداوي الناس، مثلنا إنسان. في إنسان مثلك ولكن دوره وزير. هذا إنسان مثلك ولكن دوره ضابط. نحن متساويين في الإنسانية ولكننا مختلفين في الأدوار. ولما نقول أدوار، شنو أدوار؟ أدوارنا يا إخواني وأخواتي، أدوارنا هي رسالتنا في الحياة. شنو رسالتنا في الحياة؟ يعني الله كلفني أنا أعبد الله من خلال التدريب. الوزير يعبد الله من خلال إدارة الوزارة هذه. الطبيب يعبد الله من خلال يداوي مرضاه. الفراش يعبد الله من خلال انه يجيب لكم شاي كذا. نحن مو احسن من بعض، دورنا مختلف، نحن متساويين، كلنا بشر، كلنا انسان دور مختلف. اوعى تنسى انسانيتك وتشتغل بدورك. لا، انا لان دوري فانا احسن منك. لا، ما في احد ما احسن من حد. انا الان مكلف من الله، هذا دور قد يغير دوري. ممكن بكره رسالتي تتغير. الى الان انا الاختبار اللي بدخل فيه اختبار على ان انا كيف اعبد الله من خلال تدريب. انت الى الان محطوط في اختبار كيف تعبد الله في التعاون من خلال العمل. معالي الوزير يعبد الله من خلال القاضي، نفس الشيء الفراش، نفس الشيء. قد يتغير دوري، ممكن بكره انا اطلع من التدريب اكون موظف. شوف، رسالتي تغيرت، الله غير لي اختباراتي راح ادخلها. مو انه والله انا مدير احسن منك انت موظف، انا فني، انا طبيب اعلى او اعتبر شغال بالدور. هذه ادوار، هذه ادوار الله كلفنا فيها. اوعى نحن التعامل بيننا بالانسانيه. نحن كلنا بشر وانسانيتنا متساويه. اتعامل مع فراش انسان مثلي ولكن دوره مختلف عن دوري، رسالته مختلفه عني انا. هذا جاي ينظف الوزاره، انا جاي ادي هذا العمل، هذا جاي في الجوده، هذا جاي، كل واحد يؤدي دور. لكن لا والله، احمد ربك من كلام. لا يحق لاي موظف اهانه زميل له سواء كان اعلى او ادنى منه مهما حصل. هذا اللي قلت لكم شرحته. اذا قمت بزياره زميلك فليس من الذوق ان تجلس على كرسيه وتستخدم حاسوبه او تعبث بالاوراق والمستندات الموجوده على طاولته. حتى لو ما حد لازم تساله، تتصل فيه تقول يا فلان انا ترى بفتح درجك، انا مضطر قاعد ادور على رساله بصير على مكتبك. لازم تتخيل يفتح درجه وحط صوره زوجته مثلا. درجه هو هذا، المفروض انه ما حد، يمكن اوراق جواز زوجته شيء حار، ما يبي حد يشوف. طيب، ليس من الذوق السليم ادخال مأكولات ذات رائحه قويه في الوزاره. طبيعه عمل الوزاره ان ممكن بعض المكاتب يكون في مكان للاكل. ترى ما حد قايل لي في الوزاره بتقول ها مخبرينا، لا والله ما حد خبرني. انا قاعد اقول هذا في كل الوزارات، في كل الدوائر اقول اذا لكم مكان، مثلا بعض الوزارات بعض المكاتب له مكان اكل موظفين، اذا موجود مكان تاكل فيه تغلق وما حد يشوفك، كل اللي بتاكله ما حد بيكلمك. اما اذا كانت طبيعه عملك انك تاكل في المكتب، فما تجيب لي سندويش وفيه ثوم والريحه فايحه. جايب لي شيش طاووق وثوم والريحه ما يحتاج. او انه جايب لي الحبيب فول وجايب لي بقدونس وجايب لي نعناع وفرش لك الحبيب، حط الحمص وزيت زيتون جايب لك بعد، زيت الجوف جايب، ها والبيك، نعم جايب لي البيك والريحه ما يحتاج. لا، وتعرف شو المشكله؟ يبدون ياكلون، يجيهم مراجع يقول له قرب قرب قرب، الله جابك قرب. شو جابك؟ الله جابك قرب، هذا مو بيتكم الغالي، هاي وزاره مكتب للدوله هذا، ما في شيء اسمه حماتك بتحبك حياك. لا، مرفوض هذا الكلام. اني اكل بشكل خفيف بدون ما حد يحس فيني واروح. اما جايب ذبيحه كل يوم، جايب واحد بيك رايح جاي، ريحه الثوم في المصعد، مراجع جاي ريحه الثوم في المصعد، ليش؟ ترى فلان طالب، شباب طالبين بيك. او حبيب ما اكل زيت زيتون، ها ومخللات هذا مرفوض، مرفوض. ولا باللي سمن شكشوك، شكشوك على الأقل ما فيها ريحة وحليلها. فلازم أراعي حتى البيض، ترى البيض المسلوق في ريحة ترى، حبيبي ياكل لي بيض ويدور وريحة ما تقول داخل وزارة، تقول داخل مطعم. لو أنت كنت وزير وأنت تدري أن الوزارات بينهم منافسة، ترضى تشوف موظف ياكل؟ لا ما ترضى. مشويات أهلا، مشويات غداء ولا يفطرون فيه بعد. نعم، ما غير، لا أخاف يبون سمك مشوي، كبسة أهلا يا نايف. انزين، أنا هل بلغت؟ اللهم فاشهد. أنا من كذا أقول نحن محتاجين سمك في العناية. سمك مشوي في عناية مركزة. والله إن في نقاط قريتها في الملاحظات، أنتم تخيلوا إن مريضة نايمة في المستشفى والممرضة حاطت لها مغذي وفاتحة تليفونها تكتب. والله مزعج، مزعج جدا. وانت، انا بعطيك قوانين كونيه ان شاء الله يوم بيجي الوزاره بتكلم كيف الجسم الاثيري للانسان يتاثر فيك، انت كيف تتاثر، انت تتحرى هذه الامور تمر مرور الكرام. اقسم بالله العظيم، صدق الله ومن اصدق من الله قولا. الله يقول: وجزاء سيئه سيئه بمثلها. والله ان اللي تسويه في الاخرين اقسم بالله انك بتذوقه. عندي دورة، في الدورة هاي في اليوم الأول نحن نكشف لك هذه الأمور كلها. ترى الذنب اللي هو خطأ بينك وبين الله، السيئة ترى هو خطأ بينك وبين الناس. ترى أنت هذه أي شيء، وجزاء سيئة سيئة بمثلها، مو بس شيء وترهقهم ذلة. هذا وعد من الله إنه بينذل وبيهان في أكثر من مكان. ترى وجوههم مسودة كقطع من الليل مظلمة. لا تفكرها عادية، لا تفكر ان الموضوع موضوع بسيط، لا والله انه اخطر مما انت تتصور. من كذا اقول لك ان لما ناخذ دوره متكامله، انا اوعدك ان الموظف يتغير، لان نكشف له بعض الاسرار. بعد ما تنكشف له الاسرار الامور تتغير عنده. طيب، والله اني انا اشبك اكثر من مره والبرنامج يطلعني. ودي يعني اشرح لكم اكثر واكثر، لكن شويه من كذا ان شاء الله الدوره الجايه تكون وجه لوجه. الابتعاد عن المجاملات غير الضروريه في العمل. ما اقدر اجيب هديه حق زميلتي، والله شو يقول، والله انا جايب تليفون لي ولها، ليه؟ قال بس كذا يعني جبت حق زميلتي. لا يا حبيبي، في العمل ممنوع، جنسين مختلفين ممنوع تجيب له هدايا، ممنوع الورود، ممنوع الحلويات، ممنوع العطور، بالذات عطور حلويات ورود ممنوع. ليش؟ لان كلها لها علاقه بالمشاعر. طب انت تقول جبت هديه حق زميلتك، زميله بكره تعطلت، من اللي يحب الريحه هاي؟ الورود نفس الشيء والحلويات نفس الشيء. ممكن ان مجموعه مثلا يجيبون مثلا من القسم، شباب القسم او بنات، يجيبون هديه حق شخص، مثلا مناسبه سعيده كذا، نجيب نيابه عن الشباب ما تكون لا حلويات ولا عطور ولا ورود، غيرها هديه، ممكن هديه المكتب كذا، نقول والله هذه مجموعه هديه للشباب. الالتزام بالاماكن المخصصه لكل شيء، انك ما تاكل الا في الاماكن اللي خصصوا لك الوزاره. حتى الصلاه، مش كل واحد في المكتب يبي يصلي. كل واحد في المكتب، اعتقد ان الكنترول في رسائل بس، يشعروني في حاجه بتطلع بس بتشوف شو انا ما افتح تليفوني وقت الدوره، بس افتح ودي اكمل، ودي اتكلم اكثر مم. طيب طيب طيب، كنت بقرا رساله، ما بقول لكم من مين، ما بقول لكم. طيب احيانا الفضول، البعض ياكل، مين اللي قاعد يكلمه، مين اللي قاعد يرسل له فضول. فما اكل الا في الاماكن المخصصه. حتى الصلاه يا اخواني، الوزاره تخصص مكان للصلاه، ما يجي مرضى مقفله الباب، ليش؟ قال والله الخوات يصلون. لا لا، في مكان مخصص للصلاه. يعني الصراحه في المكتب تصلي، في المطبخ تروح يصلون، ما يستوي. هذا غلط يا اخوان. حتى في المول، مول النخيل، انا اروح مول النخيل في مسجدين ومسجد شكبره وما اجمله، لكن الاقي الحريم يصلون في كوفي شوب امام المحلات والله اروح باتشي كوفي كل الحريم يصلون، انتظر ليش يخلطون صلاه؟ لان قاعد يصلون. لازم نقدم ديننا بشكل سليم. في مسجدين في المول. في الوزاره نفس الشيء، الوزاره مخصصه مكان للصلاه. حتى الوضوء، الحبيب طالع لي هاي يمشي، لا إله إلا، والعقال هنا طلع لا إله إلا الله، صلاة، 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 ويمشي ويصبصب منه ماي ولا ويقول اكتب أيوه شوف أيوه لا هذا غير لائق. إذا بتتوضأ في دورة المياه القريبة لمكان الصلاة وأتوضأ وأطلع من دورة مياه، أنت في وزارة، وزارة هذه الدولة، أتنشف بكامل أناقتي أمشي في الممر، مو تمشي أنا في بزنوبة يمشي لي في الممر والماء يصب منه والصلعة طالعة ولا، وبكل مقطع صلاة يا أخوان، صلاة يا أخوان، يا أخوان صلاة. وين عايشين نحن؟ وين عايشين؟ أنا أدري أن هذه الأمور تحصل ومحتاج أن أتكلم بوضوح، لازم أتكلم بوضوح. أيضا المواقف أنك توقف في المكان السليم. مرة أقول لكم في ناس عندهم لقافة سبحان الله. وقفت كان عندي اجتماع في وزارة الصحة قبل كورونا، فوقفت سيارتي ونزلت جاني واحد قال لي لو سمحت، نعم، قال لي وقفت كذا خليه اترك فاصل اكثر لان هذا وهو طالع ممكن يخبط فيك. قلت لا ان شاء الله واضحه. قال انت وين رايح؟ قلت رايح وزاره الصحه. ايش عندك؟ ايش لك؟ اول شيء ليش موقف سيارتك؟ لا قدمها شوي 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 يا اخي ايش لك؟ سيارتي انا يعني انت حريص علي اكثر مني؟ مشيناها. وين رايح؟ قلت رايح وزاره الصحه. ايش عندك؟ عندنا اجتماع مع مين؟ وانت ايش لك يا اخي؟ ترى هذا موجود حتى في العمل، ترى موجود حتى في العمل. اشتكيت عليه بعدين. استغلال أدوات المكتب مثل فاكس وطابعة وغيرها لأمور شخصية، واستغلال المستخدمين الفراشين. الفراش اللي موجود ما يستغل، أنت موجود عشان يقدم خدمة داخل المكاتب، إنه ممكن مراسل يجيب لكم شاي بس ما تحصله. تعرف ليش؟ شباب أرسلوه يجيب لهم سندويشات، ويا ريت الكل يطلبه مرة واحدة يروح يجيب، لا روح جيب فلان، فلان راح حندور على فلان. فراش ما تلاقيه لأنهم رايحين يجيبون أكل، دخان، سندويشات، عصاير. لا هذا خيانة أمانة. إذا الإدارة ما عندها مانع، إذا الإدارة ما عندها مانع إنه ممكن مثلًا في وقت معين يروح يجيب، ممكن، بس كل شوي ولا هذا يعطيه 5 هذا يعطيه 10 هذا يعطيه 3 والحبيب مستفيد، مستفيد. لا بعدين تقول لي صدقة، مو صدقة هذه، لعلمك هذه مو صدقة، منفعة، لأنه راح جاب لك فطور أعطيته الباقي. الصدقة إني أنا أعطي بدون أي مقابل، مش إنه والله لأنه جاب لي حسابي 13 ريال وهو أعطيته 15 قلت ريالين صدقة له. لا بس أنت تقنع نفسك إنها صدقة لكن هي مو صدقة، هي منفعة، إنه قدم لك نفعة شخصية، وهذا ما يسمح لك لأن هذا الإنسان أصلا عمله في الوزارة مش مدرج من ضمن جوب ديسكربشن إنه يروح يجيب أكل حق موظفين. ليس من الذوق السليم تصليح الهندام والمكياج امام الزملاء. بالنسبه لاخواتي البنات او بناتي، ان بتعدل ميك اب عيب ان تعدل ميك اب في المكتب والناس جالسين، خاصه اذا كان في شباب معاكم. لازم تروحين دوره مياه او مكان تنعزلين وتعدل الميك اب. اما اني افتح والله جالسه هذا غير لائق. بعض الشباب يوقف يرفع ثوبه، عدل فانيلته ونزل. عيب، عيب السروال من ملابس، عيب ترفع ثوبك، عيب ترفع ثوبك وتعدل فانيلتك. بتسوي الحركه في دوره مياه مش قدام الاخرين. ليس من الذوق السليم فتح النوافذ وايقاف المكيف دون مشاوره الزملاء. شخص دام حس عمره بردان راح يطفي المكيفات. ليش يا حبيبي؟ قال الدنيا برد. انت مو بلحالك بالوزاره، في موظفين موجودين، على الاقل على الاقل يا جماعه مو كانه برد. او نقول لا والله الجو حلو بفتح شباك. كيف تفتح وزاره في اوراق، هذه يدخل غبار في اجهزه بالملايين. يقولك لا والله الجو حلو والاوراق تطير، حاط لي كوب القهوه فوق الاوراق وحط لي التليفون عشان ما يطيرون. لا غير لا ما تفتح شباك لان في الوزاره مفروض انك ما تحمل هذه الاشياء. ابتعد عن تضييع وقت زملائك وتجنب الجلوس مكانهم كثره. ليس من الذوق السليم الحديث في المشاكل الشخصيه والبكاء والصراخ في العمل نتيجه الامور العاطفيه. انك تنقل مشاكلك الشخصيه الى داخل الوزاره هذا غير لائق. في بعض السيدات يوم يعطونك حلقات اليوم وين وصلنا، والله امس وديت المحكمه وقالوا لنا. طب شو يسوي الموظفين؟ شو يسوي؟ ينقل الجو السلبي اللي عنده هو الى مكان العمل، يتكلم ويبكي وتبكي وكل متعاطف. ابنها ما ينجح، عبد الله ما ينجح وما نجح. طيب وزاره الصحه شو اسمه عبد الله ما ينجح؟ كل القسم بل الاداره عارفين عبد الله ما ينجح. والله حتى الاقسام الثانيه ايش فيها بعد بينها الرسب عندهم خبر. يمكن الوكلاء مساكين يدون طلع النتائج يقول طمنونا عبد الله ولد فلان نجح ولا ما، مسكين عنده خبر من كثر ما شاف. اخواني واخواتي، نقل مشاكلك الشخصيه الى داخل الوزاره والحديث امام الاخرين هذا دليل ضعف شخصيتك. هذا دليل ضعف الشخصيه. الانسان صاحب شخصيه لا ينقل مشاكله امام الاخرين. لبعض الاخوات ان تيجي تتكلم والله زوجي عمل لي وزوجي وداني وفديت زوجي والرومانسيه، هذا رومانسيه. طب شو يسوي الموظفين؟ شو يسوي في الوزاره يعني؟ طب مو محتاج نعرف امس وين وداكي وايش عمل لك وكذا، مو محتاجين. ودي اتكلم كثير ولكن الوقت قارب على الانتهاء، وفي نقاط كثيره كان بدي اتكلم معاكم، لكن توجيه الانتقاد كنا بنتكلم عن الملابس في العمل، ولكن خلاص اضطر اني اوقف اشوف الكنترول شو عندهم. قبل ما اسلم الكلمه للمنظمين، اشكر كل من شرفني بحضوره. اعتذر اذا قلت كلمه وجرحتكم، يعلم الله ان نوع ان بعض السلوكيات كنت اكبر او اضحك، الهدف منه ان بس هي استراتيجيه التدريب انك ما تنسى النقطه، فقط انك تتذكرها وما تنساها انها تكبر في ذهنك. شكرا لكم، شكرا لكل من شرفني بالحضور. لا تطلعون لان الاداره هم المسؤولين. انا بشوف اذا الدكتوره اريج اذا عندها كلام او المنظمين. بالنسبه لي انا اسلم الكلمه، واذا في اي سؤال انا حاضر. تفضلي دكتوره اذا عندك اي حاجه.
شكرا جزيلا دكتور محمد. شكرا للحضور الكريم. ذكرت دكتور محمد أنه جميعنا قطع ألماس، ولكن لابد أن نحرص على صقها. الأسئلة التي من خلال المضيئة والمظلمة، منها إن كان المقربين يتكلموا براحتهم معك، كيف تتعامل مع المواقف المفاجئة، عالمية التعامل تعتمد على عقل يفكر ومظهر يشاهد ولسان ينطق وجوارح تتحرك. الإتيكيت وتعريفه ومفهومه أنه مجموعة من تصرفات تؤدي لاحترام الذات، والتعامل الصحيح مع الآخرين أساسه التعامل الصحيح مع الذات. بطاقة العمل وكيفية التعامل معها. وتحدثت أيضاً عن إتيكيت الاجتماعات ولغة الاجتماعات، عن إتيكيت التعامل بين الزملاء. أخيراً يعني نقول أنه النجاح المهني لا يقتضي بالضرورة إنجاز ما يطلب من مهام وحسب، بل يتخطاه إلى ما قد يبديه الموظف مع آخرين في مكان العمل وخارجه، بالحرص على انتقاء اللفظ على الأناقة والنظافة الشخصية التي تناسب وتعكس طبيعة وأهمية العمل. شكرا لك دكتور محمد على جميل أسلوبك ومحتواك القيم وطرحك المميز. نلقانا خير.
جزاكم الله خير، جزاكم الله خير. وكل اللي يطلبون يقولون بستضافه مره ثانيه تحت الامر، وراهن اشارتكم تحت الامر. الله يحفظكم واشوفكم على خير ان شاء الله. وكل عام
شكرا
وانتم
لك.
بخير مناسبة شهر
بإذن
رمضان
الله
المبارك.
كل سنة وانت طيب إن شاء الله يا دكتور.
وحضرتك بصحة وسلامة إن شاء الله.
our launch event, and definitely we still have almost more than 15 minutes, so please yani, feel free to have a cup of coffee or tea and enjoy your time before we start.
Sure. Okay, thank you. See you soon.
Thank you.
احمد مبارك، الصوت واصل بالقاعه؟ صوتي واصل لو عايز اكلم حلمي؟
اي دكتور، هم قفلوا. انتوا قفلتوا الصوت؟ طيب احنا قبل شوي كنا نكلمكم على القاعه، الزوم على القاعه. اكستند الان واصلك الان، شوف. هذا هو، هذا الاخراج حقنا، خليه ياخذه من هنا ممكن. بس
حلمي، ازيك يا حلمي؟ انا شايفك يا حلمي.
حلمي سامعنا يا حلمي؟ سامعين صوتنا انت في القاعه؟ شغلوا صوتنا بس في القاعه. لا، شغل صوتنا في القاعه.
عايزين تيست الصوت في القاعه. والكاميرا يا احمد دي رايحه فين؟ باصه فين؟
خلاص، صوتك طالع في القاعه، صوتك طالع في القاعه. ممكن تقطع الكاميرا لو سمحت؟ اي حلو.
ازيك يا دكتوره ايثار؟ منوره الدنيا.
مش سامعاك.
حلمي مش سامع حلمي، اللي خليه يفتح المايك. مش سامعين حلمي.
هذا ربع ساعة شغل مالهاش وقت ممكن نسكت. اوكي؟
Music off.
Assalamu alaikum. Good evening. Well, it is our pleasure tonight to have you with us for the launch of RIMFOC. And it is our pleasure. Before we start, we would like to stand for 1 minute because we lost one of our friends, Dr. Ahmed Mukhtar. So please, can you stand? نقرأ عليه سورة الفاتحة. الله يرحمه برحمته. Thank you. مشكورين. في البداية نرحب في الأخ فيصل معجل. حياك الله، مساك الله بالخير. And it's our pleasure to have you tonight about this lovely talk about disrupt your and relating itch and rash of moderate to severe atopic dermatitis. Our speaker tonight will be Dr. Atlal Ilafi. She's the consultant dermatology and head of dermatology department at Asad Al-Hamad Dermatology Center, chairman of Dermatology Council, Ministry of Health, Kuwait, and she's the vice president of Kuwait Society of Dermatology. Dr. Atlal will talk about atopic dermatitis disease burden and unmet onset. Please, Dr. Atlal, the mic is yours.
Assalamu alaikum. Good evening, everyone. It's my pleasure to be with you tonight, sharing experience and discussing the updates of a new medication when it comes to the management of atopic dermatitis. I would like to thank Dr. Mohammed for introducing me. Well, it's so. Huh?
Sorry for this technical problem.
Can he move the slides?
Try Dr. Atlal now.
It's fine, but can he move the slides? It's fine with me. I hate habit, and I have to. Okay. Those are my disclosures. As all of you know, that atopic dermatitis, it's one of the common chronic type 2 inflammatory disorder, characterized by erythematous, eczematous papules and plugs that can subsequently lead to excoriations, lichenifications, and oozing. It has a complex pathogenesis. Dr. Mohammed Anizi will speak about that. And it causes a significant psychological burden in terms of impairment of the quality of life. It is a common disease, has a younger age of onset. The prevalence of atopic dermatitis in pediatric age group, it reaches up to 20%. And also it is a common disease in adults. It ranges from 2 to 5%. In terms of prevalence, and over the past 30 years, the incidence of atopic dermatitis has tripled in number. Actually, the global burden study of atopic dermatitis compared to other diseases have shown the highest in atopic dermatitis, the highest disability adjusted life years compared to other chronic dermatological diseases. The severity prevalence, if we are looking into the prevalence in Europe and US, actually both of them, they showed that the atopic dermatitis mild form is having the 2/3 of the prevalence, and almost 1/3 or little more comes the moderate to severe form, which is quite significant number. Next. Can we move the next slide, please? The one previous. Yes, in terms of symptoms and the lesion distribution, we know in addition to the classic flexural areas, the face and neck comes in very quite distressing areas, plus the sensitive areas. And in addition to that, any visible lesions will really have a great impact on the quality of life of patients. If we are looking into the effects of atopic dermatitis, it is not only the visibility of the lesions and actually the persistence of symptoms when it comes to the itch and the vicious cycle of the itch-scratch cycle. We are seeing only the upper part of the iceberg. There are different sequelae of the disease. It may lead the patient to go frequently to the OPD or sometimes even got admitted because of severe atopic dermatitis. It causes a quite significant sleep impairment and sleep disturbance, and also it affects the mental health of the patient when it comes to the anxiety and depression. It causes a significant economic burden on the healthcare, and also it reduces the quality of life, plus it is causing a burden on the caregivers, especially in the pediatric age group. If we are going to look into the symptoms which bothers patients, in a cross-sectional study of adult patients having atopic dermatitis, 77% out of patients, they reported dry skin affecting their quality of life, whereas 50% of patients, they think that scaling of the skin is also adding to the impairment of their quality of life. Also, the fissuring of the skin and the oozing and the bleeding tendency is quite affecting the quality of life. This is a study reported in the phase 2 clinical trial of dupilumab. They did a survey among patients, adult patients of atopic dermatitis. 85% of patients, they reported having itch on a daily basis, whereas 61% of patients, they reported that this itching is severe or unbearable. Also, 42% of patients, they were experiencing itching more than 18 hours per day, and 77% of patients, they reported pain associated with the atopic dermatitis. When it comes to the sleep disturbance, actually patients with atopic dermatitis, they have a doubled increased odds of sleep impairment compared to non-atopic population. We are going to compare atopic dermatitis with psoriasis, one of the chronic diseases in dermatology. In terms of the quality of life, atopic dermatitis has a greater impact on the quality of life compared to psoriasis. If you can look into the purple and orange graph, it showed that there is a right shift of the severity when it comes to moderate to severe atopic dermatitis compared to psoriasis. So there is a great affection on the quality of life. Atopic dermatitis is not only a disease confined to the skin, it's a type 2 inflammatory disorder which has an association with other type 2 inflammatory diseases, not only to the skin, to the GI, to the bone, and in addition to that, the mental health affection and also susceptibility to metabolic syndrome. Atopic dermatitis, when it comes to the mental health, it's affecting hugely the anxiety and depression. Actually, patients with moderate to severe, they score higher compared to mild atopic dermatitis in terms of the hospital and anxiety depression scoring, and also the hospital depression scoring. Also, atopic dermatitis is affecting indirectly the economic burden by affecting the productivity of the patients of atopic dermatitis. Here on the left graph, it is showing the missing overall days of patients having atopic dermatitis. Almost more than 57% of patients, they miss some of their working days because of the disease. And whenever the severity is more, the number of disease missing is more. It's not only about missing working days. Even if patients is attending the work, their productivity or their quality of work is affected. Can you move the next slide, please? Can we move the next slide? يا تغيرون البطارية مالته يا Yeah, this is showing the presentism and the absenteeism, where patients are absent from working days, or they are presented, but they are non-productive during their work. So this is a comparison showing a highest score in moderate to severe atopic dermatitis compared to the milder form. This is also showing the mental health affection. Patients, they are having 1.9 times more probability to have an anxiety and 1.8 more chance to get depression compared to the non-atopic patients, and also sleeping disturbance. If we are looking into the direct economic cost, these are some data from UK, Germany, and USA. It shows that the highest economic cost is detected when dealing with atopic dermatitis patients. So to summarize the atopic burden, we know that the disease is causing an intense itching, pain, and affecting the mental health, also affecting sleep. Socially, patients are a little bit withdrawn. They have a problem in their work, attending their work, functioning properly. Altogether is reducing the quality of life of patients. Going to the unmet needs, yes, especially in the field of management of atopic dermatitis, they did a survey from patients to look into patients' opinion about their management. It's been found that only 14% of patients, they reported that they are satisfied with the management, whereas 9% of patients, they think that they are receiving the right treatment. On the right side, the graph is showing that patients are going to different doctors before being satisfied or before sticking to only one treating physician. The standard management of atopic dermatitis start with topical treatments in the form of emollients, topical steroids, topical calcineurin inhibitors. If patients is not responding, doctors will think of systemic treatment or going to phototherapy. If patient is not responding to phototherapy, we'll think of the systemic treatment, the conventional systemic medications that's been used over years, like cyclosporin, which is only approved in Europe, methotrexate, steroids, mycophenolate mofetil. All of these medications carries their side effects, carries the need of frequent monitoring. Plus that it's not approved. They are been used as off-label medications. What's new in the treatment of atopic dermatitis is the targeted therapy, the biologics and the JAK inhibitors. Given the chronic nature of the disease, we need to look or to choose an option which is effective, sustainable, and also in terms of safety will not have such concern. So what are the unmet needs? Yes, we are looking for a medication which is safe, effective, sustainable, and it has a convenient dosing for the patient, because since it's a chronic disease, we want patient to adhere to the management plan, because patient non-compliance will affect the overall outcome of treatment. If we are looking for unmet needs from patient perspective, patients wants to get a clear skin, wants to get rid of his itching, get clear from his pain and visible lesions, and also he wants a reduction of the flare of the disease. We as dermatologists, we are looking for an effective treatment, safe treatment, and safe treatment in terms of long-term safety. Do we like to have different options in terms of injectables, orals? Yes, we like to have different route of administration and different dosing scheduling. It will help us in deciding which management plan will be suitable for which patient. We mentioned that topical treatment can be helpful in certain number of patients, but unfortunately we are seeing that some patients, they are not applying frequently the creams. Why? We know that having larger areas of eczema, applying frequently topicals with this messy or stingy feeling is really not comfortable to the patient. Also, patients may report that whenever they apply the cream, they will have burning or they will have stinging, or they are scared from the side effects of topical steroids using them on larger surface areas. In a study, international study of life with atopic eczema, they've reported that patients having a flare, usually they have 6.1 day delay before starting a topical treatment, which may be partly explained by the fear from the side effects of topical steroids, and maybe because of difficulty in adhering to multiple applications over the day. Even the caregivers, I've noticed that even in pediatric age group, caregivers are a little bit having difficulties in applying the creams on daily basis for their children. Phototherapy treatment, yes, it's one of the good option of treatment in terms of systemic treatment or pre-systemic treatment. Phototherapy, usually we are using the narrowband UVB for treating atopic dermatitis. It's a very safe modality of treatment, provided that the patient is cooperative. Even in younger age group, we can use it. The only limitations of phototherapy is the frequent sessions during the week. So patient has to spare his time in order to attend the center or the hospital to receive the session, which is not always easy or applicable to that patient. Also, especially in the acute flares, phototherapy may not be the suitable option treating the acute flare of atopic dermatitis. And in patients who have worsening of symptoms with sun exposure, also phototherapy will not be a good option. Is systemic treatment underused? Yes. Through different surveys and clinical trials, it's been estimated that only 33% of patients having moderate to severe, they are categorized as severe, and only 8% out of those is receiving a systemic medication. 7% of severe atopic dermatitis received any systemic therapy. So there is under usage of systemic therapy and management of atopic dermatitis. Why? There are different causes and different theoretical reasons. One of them, maybe some countries, they don't have all medications which is approved for the use of atopic dermatitis. Other things, the limitation of the efficacy of the medication or the fear from the side effects, either from the patient or from the treating physician. Or maybe we are not categorizing atopic dermatitis severity in a proper way, not using the proper assessment tools to figure out who are the proper candidates for systemic treatment. There is no single systemic treatment which is very helpful in each case. So if we are going to talk about dupilumab, yes, it's been approved in the year 2017. It was a rescue medication for us. We are very happy to use it, but dupilumab will not work for every patient. So there are certain patients who are non-responsive to dupilumab or who are in need of concomitant topical treatments while in dupilumab. So to summarize the unmet needs, yes, we are looking for patients' dissatisfaction. We have to work on that. And also figure out why there is a delay in the systemic and the topical treatment of atopic dermatitis, and also proper assessment of the patients of moderate to severe in order to start the treatment, and also the variable medications which is available in different regions also can be a cause of the unmet needs. Thank you.
Thank you, Dr. Atlal. We'll keep the question until our second speaker will be Dr. Mohammed Anizi. Dr. Mohammed Anizi is consultant dermatology and dermatopathology at Amiri Hospital. He's the chairman of Faculty of Dermatology in Institute of Medical Specialization, KIMS, and the head of dermatology department at Dar al-Shifa Hospital. Dr. Mohammed will talk about atopic dermatitis, pathogenesis, and RINFOC mechanism of action. Please, Dr. Mohammed.
Thank you, Dr. Mohammed Atabi, for this introduction. I'm glad to speak in front of you today about pathogenesis of atopic dermatitis, mainly related to the mechanism of action of RINFOC, which is JAK inhibitors. It's glad to be back for face-to-face lectures, although to be honest with you, I'm starting to like the virtual lectures sometimes, you know. So these are my disclosures. So atopic dermatitis is a very common disease. It has a chronic relapsing course characterized by pruritic conditions that comes and goes from early years of life. It is associated with atopy, as you most of you know, and in some patients they have family history of a similar disease, or maybe in most of them. There are two phases, acute and chronic. It depends when the presentation is. In acute disease, usually more itchy, more oozing, and as the time goes, you have the liquefied, dry, thickening of the skin. If you do a biopsy of the acute cases, sorry, what is the pointer here? Yeah, that's the pointer. Yeah, if you do biopsy of the acute cases, you get mainly spongiosis and acute inflammation with a little bit of epidermal thickness. But as the disease become chronic, as you see here, you get more acanthosis and more fibrosis, more hyperkeratosis, and that will become very hard to treat in some patients. This is the most common itch and scratch cycle that has been described in atopic dermatitis. You see the patient who scratch, become inflamed, and then itch, and then it's a vicious circle. You know why the inflammation is there. There are two hypotheses. One is inside, outside. The other one is outside, inside. From the name outside, that means there is something going on from the outside with a problem in the barrier, and then skin barrier defect, which lead to entrance of the allergens or of the microbes to start the whole process, the whole inflammatory process. The other theory is inside, outside. That means there is a genuine immune dysregulation in the patients that will start the whole thing. And the barrier dysfunction is secondary to that. Maybe when the region started, we have both theories are true in most of patients. What are the epidermal barrier dysfunctions? We normally, for normal skin, you need a very intact stratum corneum. So the stratum corneum is very important. This is the upper layer of the skin. In patients with atopic dermatitis, there are reported mutation and abnormalities in the stratum corneum in terms of decreased filigrein, decreased loricrin and involucrin with abnormal lipids. If you go back to the previous model of brick and mortar of atopic dermatitis, imagine the bricks are the keratinocytes, and what's holding the keratocyte together is the epidermal lipids and the junction. When you have problem in that, you will have abnormal barrier and you will have entrance of the allergens and of the microbes that will lead to the clinical manifestation that's seen in atopic dermatitis. Something important, we know that eczema is very itchy condition. So once you scratch, that will actually increase the burden or the already disrupted barrier and will increase your barrier dysfunction or the permeability of the allergens. And most of the cytokines reported, they induce the pruritus or the itchiness in patients with atopic dermatitis. What are the cytokines, the key cytokines involved in the pathway of the pathogenesis of atopic dermatitis? Mainly IL-4 and IL-13, but others too, IL-31, IL-22, and others. They basically what they do, when you have a lot of those cytokines, you have inhibit keratinocyte proliferation, increase keratinocyte proliferation with inhibition of the lipid synthesis and the inflammatory process that's seen, as you will know later. So how they do, when you have the cytokines attached to the receptor, they induce the JAK and STAT pathway that signal the outside of the cell to the inside of the cell, and this will promote the function of the inflammation, increase the inflammation through the transcriptional factors. So what they do basically, this cartoon is nice. You have the cytokine attached to the receptor that will lead to dimerization of this receptor. And then you have cross-phosphorylation of the JAK, and you have to pay attention to that because this is the idea of our lecture. And then after that, these activated JAKs will induce the STAT molecule to be dimerized, and then this important molecule will go into the nucleus and produce the will lead to transcription and reduction of the pro-inflammatory mediator. And this is very simple, but this is the usual or the most common pathway that's seen with those cytokines. This is a very complicated cartoon here to compare the healthy skin to non-lesional and then acute and chronic. Sorry for that. That's the one, yes. So as you see, in healthy skin, you get only a normal barrier without any inflammation. In patients with atopic dermatitis, even non-lesional skin will show the abnormality, and they have disrupted barrier that will lead to antigens or allergens or microbes, whatever the antigen is, present themselves to the immune system, and that will induce the T helper cells, namely Th2 mainly and others too. The other important T helpers, T17, T22, and even T1 Th1 can be upregulated in chronic conditions. So what are the pathogenic factors or pathophysiology In the epidermal dysfunction, you have filaggrin gene mutation, increased skin pH, decreased resistance of Staph aureus or microbes in general. There is problem with the antimicrobial peptide. And decreased ceramides, that's the important lipid that's present in between the keratinocytes. And of course, xerosis. Other important aggravating factors is the history of atopy or dry skin and seasonal changes, heat, sweating. That's all aggravating factor to atopic dermatitis. Immunological abnormality can be seen with increased Th2 cytokines, namely IL-4 and IL-13, increased serum IgE, and increased transepidermal water loss. So it's very complex disease, as you see here. We have different group of patients. We have patients who actually have seasonal, only very mild episodes, and then nothing for the whole year, and then it comes back after, which is a mild disease. Then we have patient who has frequent episodes with periods of remission and exacerbation, and that's the most common patients. For the severe cases, either we have longer episodes or with short period of, sorry for that, I have to get this away from me, with short period of remission, or we have a constant disease. And that's very severe cases with some, during the consistency of the disease, we get periods of exacerbation. And when you have the graph 3 and 4 and 5, that's a severe disease. We have different morphology and presentation. It depends on the age group. For patient in the infantile stage, you get mainly facial and extensor involvements. As they grow older, they go to the flexure. In the adult life, we get mostly flexural involvements with involvement of the high impact areas, the face and head and neck and hands. Another important findings, it depends where you are in the world. In your ethnicity, we have different pathophysiological, they all share the Th2 activation, but it depends where you are. For example, if you're an African American, you have mainly Th2 and Th22. You have none of the Th17 and Th1. If you are European, on the other hand, you get all of them, mostly Th2, but you get all of them. So why I'm saying that, because when you have a different prognosis or different natural history, different presentation, and different ethnicity, when you have patients with different ethnicity, you cannot use one treatment for those. As you remember this one earlier, if you block one of them, if you block the IL-4, for example, it will work, but the other pathway is still active and might produce the disease. They all share their function by the JAK and STAT pathway. So when you block those JAKs, you will able to prevent the disease in most ethnic group and most patients. So how RINVOQ is working? Before going into RINVOQ or obadicitinib, we have 4 mainly JAK in our body. We have JAK1, 2, 3, and tyrosine kinase, and those they're all involved in atopic dermatitis. Once you block the JAK, there's no pointer here, but you see the JAK inhibitors interfere with the phosphorylation of the JAK molecule, and that will prevent the function that we saw in the other video earlier. The inhibition is actually reversible. So once you decrease the dose of the JAK, that will promote phosphorylation and the function will come. Why this is important? Because when you want to stop the treatments, you can use it as a rescue treatment in some patients. That's what they said here, fast on and fast off, without interfering with the main function in the body. This is the JAK one, that's the main one that involved in atopic dermatitis. In the circle here, you get the site of attachment of obadicitinib. This is the site of phosphorylation. So what the JAK inhibitor is doing, it interferes with the phosphorylation in that area, and this will prevent or block the JAK from functioning. It has usually higher affinity or the selectivity of obadicitinib. We have 3 main, first of all, we have 3 main JAK inhibitors approved for atopic dermatitis. We have obadicitinib, baricitinib, and abrocitinib. Obadicitinib is actually has higher selectivity to JAK1, which is the main one in atopic dermatitis, compared to the others. And even that's seen in the studies with higher efficacy and to reducing symptoms of atopic dermatitis. They're all approved in most part of the world. Maybe baricitinib is not approved yet in the US, but it will be approved. and they can be used for, as we'll see later, for atopic dermatitis patient with moderate to severe. Thank you for listening.
Thank you, Dr. Mohammed. Well, our next speaker will be Professor Melinda Guderman. Professor Melinda, she's working in Skin Center of Dermatology, Pittsburgh, Ontario, Canada, probably medical research, Waterloo, Ontario, Canada, Queen's University, Kingston, Ontario, Canada. Professor Guderham, she's dermatologist and medical director at the Skin Center of Dermatology and an investigator with probably medical research. She is assistant professor at Queen's University and consultant physician at the Peterborough Regional Health Center. She's a fellow of Royal College of Physicians and Surgeons of Canada. Professor Guderham, she has been principal investigator for 170 clinical trials, and she is practical with focus inflammatory skin disease. She is also contributed to several peer-reviewed dermatology publications as an associated editor, reviewer, and she is an author of 150 articles. She enjoys lecturing to global audience on the new therapies for skin disease. Professor Melinda will talk about Rinvoq in atopic dermatitis, efficacy and safety. Prof. Melinda, the mic is yours.
Thank you very much for that kind introduction, and thank you very much to the previous speakers for giving an excellent background, not only on the burden of disease, but also on the pathophysiology and explaining how a medication like upadacitinib will work. Here are my disclosures. And so starting into Rinvoq in atopic dermatitis, as you know, this meeting is sponsored by AbbVie. Disclosures again. So we'll start off by considering upadacitinib, that this is not only an atopic dermatitis drug. This medication has been approved and studied in almost 12,000 patients in a number of diseases. We have approval since 2019 in moderate to severe rheumatoid arthritis. We have psoriatic arthritis, ankylosing spondylitis, and atopic dermatitis receiving approval in 2021. So quite a number of inflammatory diseases already receiving approval around the world. The atopic dermatitis program included over 2,500 moderate to severe AD patients. And here's just a summary of the pivotal trials. We have the two monotherapy trials, Measure Up 1 and Measure Up 2, and the combination study Add Up, which is a combination with topical corticosteroids. And then we have the Heads Up study, and this is monotherapy upadacitinib versus dupilumab. But compared to the Measure Up 1 and 2 and Add Up, which included ages 12 and above, Heads Up is just 18 and above, because when the study was designed, that was the approval for dupilumab at that time. So very similar population in each of these studies, except the age in Heads Up and the different treatment arms, upadacitinib 15 milligrams, 30 milligrams, or placebo, or in Heads Up where it was head-to-head with dupilumab. So just a quick review on the study design, which is very simple. Patients were randomized 1:1:1 to either upadacitinib 30 milligrams, 15 milligrams, or placebo for the first 16 weeks. The placebo group was then re-randomized to the two doses of upadacitinib. Here are the co-primary endpoints at week 16 was an EASI-75 and an IGA score of clear or almost clear, or 0-1 at week 16. And in the first 16 weeks, if patients used a topical corticosteroid in this study, they were considered non-responder, but they could use this as rescue therapy from week 16 to week 52. So here are the co-primary the EASI-75, one of the co-primary results in both Measure Up 1 and Measure Up 2. So you can see ranging from 73% to 80% EASI-75 rates in the 30 milligram dose and 60 to 70% in the 15 milligram dose. Another thing to point out here is the rapidity of response that we saw, where almost half of patients were achieving an EASI-75 by week 2 in the 30 milligram dose. So you really can get that rapid improvement that in the past we may have expected from cyclosporin or prednisone. We can actually see that with upadacitinib. And then it continues to improve till about somewhere between week 4 and 8, where then we get a stable response that's maintained, showing here up to week 16. Here's just an example of a patient beforehand at baseline, an EASI score of 32.7 on the 30 milligram dose with a good response by week 16. He's down to 6.4. So if we look at a higher bar of response, which would be an EASI-90, and it's not something we talk a lot about when we're previously when we were talking about atopic dermatitis therapies, because we don't have a lot of drugs that get us there. But we saw 59 to 66% of patients achieve an EASI-90 by week 16 in the 30 milligram dose, and 42 to 53% of patients, so about half patients in the 15 milligram dose, achieving an EASI-90 by week 16. And another example of a patient on 15 milligrams a day, quite severe at baseline, 43.7 is his EASI score. You can see widespread erythema and excoriations. And by week 2, you already see fewer excoriations, reduced erythema. And by week 16, he is almost clear with an EASI score of 1.6. The IGA response rate, an IGA 0-1 or clear, almost clear, in Measure Up 1 and Measure Up 2, anywhere from 39 to 48% in the 15 milligram dose and 52 to 62% in the 30 milligram dose. So about half of patients clear, almost clear. What happens beyond week 16? The patients do have a chronic disease. Here we are looking beyond week 16 at observed data. So patients who, number one, patients were allowed to use some topical steroids in this second portion, and we're only looking at observed data. So any patient who may have dropped out are not considered here. And what we see is that high level of response of the EASI-75 at week 16, which is then maintained in the solid line, which is the 30 milligram dose, 85% of patients maintaining that EASI-75 skin clearance throughout the first year, and 81% of the 15 milligram dose maintaining that EASI-75 response. Same with EASI-90, that higher bar, 72%. See a nice flat line with the 30 milligram dose, 72% achieving an EASI-90 from week 16 and maintaining throughout that first year. And with 15 milligram dose, it's 62%. Again, these are observed data. So Add Up is a very similar, almost identical study design as Measure Up 1 and Measure Up 2, except that all treatment arms were given topical corticosteroids to use in a specific fashion that they used for a number of weeks until they were improved, and then they dropped down in the potency. So this was not as needed use. They were actually given a schedule on how to use their topical corticosteroids. But we have the same re-randomization of placebo patients at week 16 ongoing. And of course, we'll talk about week 52 data here, but these patients are all in a long-term extension that will be up to 5 years. So there will be more data coming beyond what we're going to talk about. So if we compare those patients without topical corticosteroids in the monotherapy studies in Measure Up 1 and Measure Up 2, and we compare that to those who were using topical corticosteroids in Add Up, in the treatment arms, we actually don't see a difference. We have 73 to 80% of monotherapy achieving EASI-75 with 30 milligrams, but we have 77% in the Add Up trial who are using TCS, 60 to 70 in Measure Up 1 and Measure Up 2 on 15 milligrams, and we have 65 in 15 milligrams. So where we see the biggest differences in that placebo arm, we do have a higher response in the placebo arm because they are using their TCS therapy. So it doesn't seem to make much of a difference in those who are already being treated. And that is in comparison to many other medications that we use where adding in a TCS really makes a big difference in skin clearance. So the other important thing that was discussed earlier in the first lecture was that importance of itch, the burden of itch, how it impacts the patient's quality of life. And what we see here is that rapid and significant relief of itch. So considering the worst pruritus NRS and those patients who are achieving a 4-point improvement or greater at week 16, 60% of patients achieving that target with the 30 milligram dose, and 42 to 52% achieving it in the 15 milligram dose at week 16. But if we look even as early as day 1, 10% of patients achieving a 4-point or greater improvement with the 15 milligram dose. And when you look at day 2, we have 20% of patients with the 30 milligram dose achieving that improvement. So 1 in 10 by the first day and 2 out of 10 by the second day, already having that significant benefit. And the patients will tell you that when you see them in follow-up. Some of them will even call your office to tell you how quickly the itch went away, because it's so remarkable that they want to share that with you. If we look at the kinetics over time, you can see the stability of that response. So we have improvement of the itch over the first 4, 5, 6 weeks, and then that is maintained throughout the first 16 weeks. And we see that in Measure Up 1, and we see that in Measure Up 2. Looking out to week 52, again, this is chronic condition. What happens after that week 16 point? We see stability in that itch reduction, that 4-point improvement. Again, 70% of patients maintained in the 30 milligram dose, and 65% maintained that itch improvement in the 15 milligram dose. So the quality of life that we've talked about earlier. So in this sort of heat map, what we see is if you have less than 50% response rate, you'll get an orange color. If you have 50 to 70%, you have light blue. And if you have 70 to 90%, it's the darker blue. And the first 2 columns are placebo. So we can see a lot of orange there. That means the majority of patients did not achieve improvement in quality of life based on the scores listed, the POEM, the ADERM SS, the IS, and the DLQI. In the 15 milligram dose, we see a lot of lighter blues, 50 to 70% benefit there. And in the 30 milligram dose, up to 90% of patients having these improvements in quality of life based on the PROs listed. So what that tells us, and it was mentioned in that first opening video, we do have rapid and lasting responses, rapid skin clearance, itch reduction. We have EASI-75 that was achieved as early as week 2 in some patients. And that itch reduction, the worst pruritus NRS of 4 points or greater, achieved in 10% of patients after 1 day, 20% of patients after 2 days, but it's lasting. So they have those early onset benefits, but they last over time. Those EASI-75 and EASI-90 response rates are maintained throughout week 52 in all of the studies that I've reviewed. Same with that itch reduction, that 4-point or greater improvement in itch that's maintained by week 16 is also sustained throughout the 52 weeks of this first data cut. As I mentioned at the beginning, there are multiple indications out there that of patients using Rinvoq. It has been around for a number of years for patients with rheumatoid arthritis. As I mentioned here, RA, PSA, ankylosing spondylitis, and atopic dermatitis, 16 phase 3 clinical trials, with AD being the second largest one. So we can get a lot of safety information as well from this type of data. So if we look at those first 16 weeks, I know that's short term for some safety signals, but it's what we have that's placebo controlled. So first we'll look at the placebo controlled safety period of 16 weeks, and then we'll look at the longer term use and some of the safety signals or whatnot that we see through week 52, which doesn't really change from week 16. But you could see this safety analysis includes the phase 2B study, as well as Measure Up 1, Measure Up 2, and Add Up. So we have over 2,700 patients, including over 300 adolescents in this safety analysis, this integrated safety analysis I'll review. And again, we highlighted here, this is short-term. We know that we're gathering more long-term information, and I will review also the 52 weeks. What we see in this short-term safety, overall AEs are slightly higher in the upadacitinib groups compared to placebo. However, when you look at what matters, there are similar rates of SAEs or serious AEs, as well as AEs leading to discontinuation. So some of those AEs in that percentage may be annoying things or tolerability issues and not what you might consider true safety. There were no deaths in this first short-term analysis. The more common events that we saw, probably the most common was acne. There is a dose response with that, where the 30 milligram dose does have higher rates of acne than the 15. The nasopharyngitis and upper respiratory tract infection were seen in all groups. Other things that we saw higher in the upadacitinib group was CK elevation. This was generally transient and not associated with clinical sequelae. And then atopic dermatitis flares were seen in the placebo group more than they were seen in the upadacitinib groups. Looking at the AEs of special interest, as you just learned about blocking with JAK inhibitors, we do have a number of receptors that are blocked so that we can treat this heterogeneous disease, but there are some receptors such as interferon signaling that may have a signal with increased herpes infections. And we see here higher rates of herpes zoster and eczema herpeticum. Of course, we can treat these and we can monitor for these and treat them early. So these are treatable AEs. There were some non-melanoma skin cancers and other malignancies in the upadacitinib group, but the rates were low in what we might see in the background population. There was VTE only in the placebo group, not in the upadacitinib group, which we often think of as, because of the RA data, but we haven't been seeing that signal in the AD population. The cytopenias, again, is dose dependent, where there's anemia and neutropenia seen with upadacitinib, higher with the 30 milligram doses. But, what we don't see any elevation of MACE, GI perforation, and those things that we may have seen in the RA data, but we are treating a different population as well. So having multiple indications can be a double-edged sword. It gives you more patients to see, but when the patients have different comorbidities, different concomitant medications are at different age, this does maybe bring up some signals that don't, are not really relevant in our population. So just some key takeaways of that short-term 16-week, overall generally well tolerated, but we did see the herpes zoster and neutropenia rates higher with upadacitinib. Anemia was higher with the 30 milligrams. There were no deaths, tuberculosis reactivation, GI perforation, MACE, or venous thromboembolism, and no other safety concerns except for those higher rates of acne. Even the rates of serious infections were less than 1% in all of the arms. The rates of SAEs and AEs leading to discontinuation were the same between upadacitinib and placebo. The more common AEs reported acne, as I mentioned, was the top one, but also the elevated CK and the herpes signal. We are collecting more data, and we will get 5 years of exposure of these patients in the long-term extension. So let's look at that week 52, remembering that we don't have placebo control during this period, but we do have the 2 doses. Highlighted here again is acne, which is the highest AE that we see, up to, could be about 20% of patients, so 1 in 5. In my experience, most of it is sort of a papulopustular form that responds well to topical therapy in most cases. We saw the atopic dermatitis. Also, the flares were less in the higher dose. We see the CK elevation, which is dose dependent, the herpes and things like oral herpes and herpes simplex. Again, we're seeing some dose dependency there with higher rates in the 30 milligrams, but that's more expected. It's not surprising. There was actually 1 death here in the Measure Up 1 study in the 30 milligram dose. However, I want to point out the patient was 67 years old who had a heart attack. was not on the medication for 4 weeks before, so had been off therapy for a month, and had a COVID infection, and then passed away from myocardial infarction. And so that was not deemed related to therapy, since he had been off and had many other good reasons for explaining his heart attack. AEs of special interest, again, the herpes signal highlighted here. Herpes zoster is something that we can prevent with vaccination. This should be something that you consider for your patients over the age of 18 with something like Shingrix. And, you know, that was not a requirement for these studies. So in the real world, if we are better at vaccinating our patients, we may see these rates a bit lower, but we need some real world data to support that. There, again, nothing new coming up here from 52 weeks that wasn't already apparent at week 16. We just have more numbers. There were a couple of venous thromboembolisms here. Again, one was in a COVID patient, a woman who had a COVID infection and had a pulmonary embolism. And then another was in, I believe, a 40-year-old woman who had a history of DVT and developed another DVT. So that shows the importance of taking a history in your patients. If they have a prior history of DVT, this might be something to either consider choosing your medication or monitoring the patient. The cytopenias, consistent, like low rates of anemia and neutropenia, but consistently dose dependent. So we'll talk a bit later about monitoring, baseline monitoring, screening patients, and monitoring blood work throughout. We saw the elevated CK. We see that with every JAK inhibitor. Like I said, it's transient and there's no sequelae, so it's not really something you have to monitor for patients ongoing. And then we can look at the safety profile in the other indications, considering that they are different ages, they have different concomitant medications, and they have different comorbidities. So just take that with a grain of salt, but do learn from it in other ways. So this is looking at a rheumatology publication on the rheumatoid arthritis integrated safety analysis. So they're comparing methotrexate monotherapy with adalimumab with methotrexate, and then the 2 doses of upadacitinib, so the 15 and the 30. And, you know, when I look at this, I think as dermatologists, we're all very visual. So what we're looking for is, where are the green and blue, the upadacitinib 15 and 30, where are they separating out from the orange and the purple, which is the methotrexate and adalimumab? And we do see them separating out in the elevation of CK on this slide. We also see them separating out with the herpes zoster. So kind of what we see with the AD population, and the rest of the AEs that we're looking at here, they're kind of not different than the methotrexate and adalimumab groups. Here is a long-term safety profile with RA, PSA, or ankylosing spondylitis. So this is sort of a combination. Again, looking for that separation. Where do we see upadacitinib separating from the other drugs, adalimumab and methotrexate? Again, here in herpes zoster, but we don't see any differences in serious infections or in opportunistic infections. We don't see any differences in MACE, and we don't see any differences in venous thromboembolism. So I think, again, supporting what we see in our patient population. So for experience, sort of across the board, and what we can learn from other disease states, we have these almost 12,000 patients across 16 phase 3 trials where we see the 15 and the 30 milligram dose and what signals we're seeing. And I think it's predominantly herpes and CK that are showing up. So when you're starting this medication in patients with moderate to severe atopic dermatitis, you have 2 doses. There's a small purple pill, which is the 15 milligrams, and then sort of a reddish brown pill of the 30 milligrams. So it's good to know that. So you can ask the patient what color their pill is if there's any concern what dose they're getting. The recommended dose for adolescents up to 18, from 12 to 17 and 65 and above is 15 milligrams. And then from 18 to 65, it can be 15 or 30, where 30 may be used in those patients with a higher disease burden. Keeping in mind that for adolescents, the smaller adolescents who are, say, under 30 kilograms, they have not been studied. What about the special populations? We do have some AD patients who have other comorbidities. So with renal impairment, there is no dose adjustment required for mild to moderate renal impairment, but you should use with caution in severe renal impairment the 15 milligram dose, and the 30 milligram dose is not recommended in severe renal impairment. Hepatic impairment, no dose adjustment in mild or moderate, but it should not be used in severe hepatic impairment. And as I mentioned, there's no exposure data available in adolescents less than 40 kilograms. So the overall contraindications, severe hepatic impairment, of course, hypersensitivity to the medication, which is listed for any drug, pregnancy, and active TB or other active serious infections, you would not give them upadacitinib. How to take it, they can use it with or without topical corticosteroids or TCIs. They can take it with or without food, and they can take it at any time of day, but they cannot crush or chew the tablet because it's a coated tablet. So to ensure proper absorption, they need to swallow it whole. As I was mentioning, with the cytopenias that can be seen with this medication, you should not initiate this medication in patients with an absolute lymphocyte count of less than 0.5, neutrophil count of less than 1, or those who have hemoglobin less than 8 grams per deciliter. And then while the patients are on the medication, we monitor them as we do with our other oral therapies like methotrexate and cyclosporin, where you would do the baseline evaluation of a CBC. You can do lipids at baseline if you choose, liver and transaminases, screen for infections like tuberculosis, hepatitis, and then you would repeat really based on your practice. It might be every 8 to 12 weeks, depending on how you practice. And then I would go on and monitor as per your regular practice. So for me, early on, I monitor every 8 weeks. When things are stable, I move on to every 12 weeks. Again, you want to watch out for those CBC parameters that I went over, and either hold or stop therapy if they develop a cytopenia. So just to summarize that patient profile, like where would you use this medication, or where have I used this medication in my practice? I do use it in patients who have previously tried monoclonal antibodies, dupilumab, tralokinumab, which are available if they are not responding first, but also if they do not, if they're having AEs such as conjunctivitis or ocular surface disease, if they're experiencing head and neck erythema that have not responded to some of the things I've tried to improve it, if they complain of injection site reaction, or they just don't like having needles, those are patients where I would use upadacitinib. Also patients who are looking for quick relief. I had a patient the other day who was just beside herself, distraught, not sleeping, suicidal thoughts at times, and I needed quick relief. And so I needed to get her better quickly, and I did, and I brought her back in 2 to 3 weeks, and she was like a new person. So there's those patients who are looking for quick relief, and then there's the patients who have special site involvement. Maybe they have very severe hand or facial neck dermatitis that need rapid relief. You have the 15 milligram dose for adolescents and the elderly, and then the 15 or the 30 available for adults from 18 to 65. So thank you for your attention.
Professor Silberg, he's working George Washington University School of Medicine and Health Science, Washington, D.C., USA. Professor Jonathan Silberg is Associate Professor of Dermatology at the George Washington University School of Medicine and Health Science in Washington, D.C., and Director of Clinical Research and Contact Dermatitis. Professor Jonathan completed his medical school training at State University of New York, Downstate Medical Center, where he received his doctorate in neuroimmunology and Master Public Health in Biostatistics and Epidemiology. His area of clinical specialization is inflammatory skin disease, particularly atopic and contact dermatitis, with extensive experience in advanced management of atopic dermatitis and other chronic inflammatory skin disease. He is a principal investigator in clinical trials for atopic dermatitis and other disorder. His publications include more than 1,000 peer-reviewed articles, abstract and book chapters. He is also author of Clinical Management of Atopic Dermatitis Handbook 2018. He is an associate editor of international journals like the Journal of American Academy of Dermatology and members of International Eczema Council, North America Contact Dermatitis Group, and American Society of Contact Dermatitis. Professor Jonathan will talk about RINFOC, a new frontier in atopic dermatitis management. Professor Jonathan, the mic is yours.
I'm an associate I'm Professor Jonathan Silverberg. I'm an associate professor research and patch testing, director of at the George Washington University School of Medicine and Health Sciences. And now I'll be discussing new frontiers in atopic dermatitis management. For disclaimer, this event is organized and funded by materials on AbbVie's behalf. All scientific data represented in this session are entirely my viewpoint and do not necessarily represent AbbVie. AbbVie does not recommend the use of any product in any different manner than as described in the local prescribing information. And before prescribing RINVOQ, please consult with the prescribing information. Please report any adverse events to the email address or hotline number shown on the screen. Now, I show you my disclosures. I am very involved in drug development and clinical trials. Some of these are potentially relevant to today's presentation, and I will do everything I can to give a fair and balanced presentation. All right, so this is going to be the layout of my talk for today. You've already heard a lot about the excellent efficacy of RINVOQ in placebo-controlled trials. What I'm going to show you next is data from the Heads Up trial, which is a really cool head-to-head study against Dupixent. We'll then talk about how to properly initiate RINVOQ therapy in patients with moderate to severe atopic dermatitis. So let's get started with the Heads Up trial. Now, the Heads Up trial is a very important study, very cool study. You know, most of the time, the studies that we have are placebo-controlled, or in the case of topicals, vehicle-controlled. We so rarely have active comparators to something that is already, being used in the real world. And here we have two different treatment arms. There's RINVOQ at the higher dose, the 30 milligram dose given orally every day, versus Dupixent with the approved dose of 600 milligram loading dose, 300 milligrams every other week subcutaneously. And this was a double dummy study. So the patients got the placebo or dummy for the alternate therapy that they did not receive. Now, this is also a very important study because not only was the comparative efficacy examined at week 16, which has emerged as the main time point assessed from a regulatory standpoint for primary efficacy endpoints, but really pushed out all the way to week 24. And of course, we really want to know long-term how patients are doing on therapy. Now, when we think about some of the key inclusion-exclusion criteria for this study, they're listed here on this slide. The study included adults ages 18 and up with chronic atopic dermatitis and moderate to severe disease. So they had to have at least a body surface area of affected lesions, 10%, eczema area and severity index score of 16 or higher. For context, of score 6 or 7 would be moderate, 20 or 21 would be severe. So this is skewed a little bit more towards a more severe patient population. And a validated investigator's global assessment score for atopic dermatitis of 3 or higher, where 3 is moderate, 4 would be severe. They also had to have a weekly average for their worst itch of 4 or higher. So a score essentially moderate to severe itch. Some of the key exclusion criteria, I should say, or washouts that one should be aware of. They had a washout of topical therapy for 1 week. They had a washout of systemic or phototherapy for 4 weeks, or traditional Chinese medicine for 4 weeks. In addition, patients were not previously exposed to Dupixent or other JAK inhibitors. So to summarize a lot of information at a very high level, in the Heads Up study, all primary and ranked secondary endpoints were met, meaning that Rinvoq showed statistically significant superiority for all of these endpoints compared to Dupixent. The primary efficacy endpoint was the proportion of patients who achieved an EASI-75 response, a 75% improvement or reduction of the Eczema Area and Severity Index from baseline out at week 16. EASI-75 responses were also assessed at earlier time points, as early as week 2. We also have the proportion of patients who achieved EASI-90 responses, EASI-100 rates, the percent change in the worst pruritus numeric rating scale from baseline, as well as a proportion of patients who had a 4-point reduction in itch from baseline, and that would be equivalent to a moderate clinically important difference of itch. All right, so let's take a look at some of the baseline demographics and characteristics. Overall, the characteristics were well balanced across the 2 different treatment arms, the Rinvoq 30 arm versus the Dupixent arm. But there are some key characteristics that I want to draw your attention to across the entire cohort. One is when we look at the duration of the disease, mean duration of the disease was 25 years. So this tells you that this is really chronic and in many scenarios, lifelong disease. When we look at the severity assessments for body surface area, Eczema Area and Severity Index, and mean pruritus scores, what we see is very high baseline scores, really consistent with a moderate to severe patient population and skewed a little bit more towards that severe patient population. Likewise, when we look at the proportion of patients who had severe IGA scores, we see that a large subset of patients in the study had severe Investigators Global Assessment scores. All right, so we've established now the inclusion-exclusion criteria. We've established that this is in fact a chronic, moderate to severe atopic dermatitis patient population. Let's jump into the results and show you that Rinvoq was really able to achieve superior skin clearance compared to Dupixent. So here we see in yellow, Rinvoq 30 milligrams orally once daily. Again, this is all monotherapy, no background topical corticosteroids in this study, compared to Dupixent at the 300 milligram maintenance dose. And what we see is that at the primary efficacy endpoint, which was at week 16, that Rinvoq was associated with significantly higher rates of EASI-75 achievement compared to Dupixent at that week 16 time point. But one doesn't have to wait 16 weeks to get to that EASI-75 response. When we look to the left at the EASI-75 responses at week 2, there we see a major differentiation where Rinvoq is markedly faster in terms of its rapidity of onset of efficacy compared to Dupixent. But even at week 16, when we look at the later time points, we see a major separation, particularly for the EASI-90 and EASI-100 response rates. And EASI-75 is about a moderate clinically important difference. EASI-90 is a really much deeper response. And that's really where we see how Rinvoq shines, this ability to get patients much, much closer to clear, much deeper endpoints, higher proportion of patients who are getting there already at week 16. Now let's talk about itch. And we know itch is so important in this disease. Itch is the most common symptom. It's also the most burdensome symptom for patients. It's what drives their healthcare utilization. So we really want to make sure that Rinvoq is working well for itch. And in fact, that is the case. We see a rapid onset of efficacy and a sustained efficacy and sustained superiority in terms of itch reductions for Rinvoq 30 compared to Dupixent. As early as week 1, we see a major separation where Rinvoq is markedly faster in terms of its onset of effects for improvements of itch compared to Dupixent. But even when you look out at week 4 and beyond, we see that at all those time points, Rinvoq maintains that superiority with respect to meaningful improvements of itch compared to Dupixent. Now, when we look on the right at the kinetics, and we see here Dupixent in blue and Rinvoq in this yellowish color, here we appreciate that, really out of the gate, Rinvoq is markedly faster than Dupixent with respect to the itch. The plateau occurs somewhere around probably week 4 to week 6 or so, and really stays nice and stable out to week 16. Whereas for Dupixent, it takes longer to achieve those kinds of improvements, but really at all time points, we see that Rinvoq maintains that superiority with respect to itch. Now, one of the interesting observations that has come up is, Rinvoq is so fast in terms of its onset of effect, and Dupixent takes longer to really start kicking in and getting those meaningful improvements. So maybe week 16 is too early. Well, what happens when we go to a later time point, especially in the context of recognizing for so many patients, this is a lifelong disease, and we need to really have good chronic maintenance therapy in order to maintain long-term control of their disease. And when we push out the additional 2 months to week 24, here we see a little bit less of a separation between Rinvoq and Dupixent for the EASI-75 responses, where for Rinvoq, it's nice and stable all the way out to week 24, but for Dupixent, it does sort of chug along and slowly but surely pick up a little bit of a higher response. But when we look at the deeper endpoints, particularly for the EASI-90, and we look at EASI-100 rates, and also for improvements with respect to itch, here we really see still that Rinvoq is superior to Dupixent for those deeper endpoints and for itch, even out at week 24. Now, whenever we talk about a new therapeutic, we can't just talk about efficacy, we have to address potential safety concerns. And so here I show you this summary slide comparing the safety profile for Rinvoq versus Dupixent through week 16. And this is, first, we're going to address the adverse events of special interest. Now, I should just point out to the audience that there has already been a presentation for an integrated safety analysis for Rinvoq across multiple trials. But this gives us a unique opportunity to look comparatively between these two drugs in terms of the safety profile. And what we see is that overall, low rates of serious infections, low rates of opportunistic infections, and even truth is low rates of herpes zoster, although in the case of opportunistic infections and in the case of herpes zoster, there is a numerically higher rate observed for Rinvoq compared to Dupixent. It's a low absolute rate, but it is a little bit higher than observed for Dupixent. Notably, there are some very important pertinent negatives. So we don't have any observed cases of active tuberculosis. We don't have any observed cases of non-melanoma skin cancer seen for Rinvoq, no cases of malignancy, excluding non-melanoma skin cancer or lymphoma in particular observed in the Rinvoq arm, and no cases of adjudicated GI perforations or major adverse cardiovascular events or adjudicated venous thromboembolism seen in the Rinvoq arm as well. Now, with Rinvoq, laboratory monitoring is going to be required, and I'll show you in the next few slides how that's going to be done. But there are laboratory anomalies that are observed. So we see higher rates of laboratory anomalies observed for anemia, neutropenia, lymphopenia, and also elevated CPK levels for Rinvoq 30 compared to Dupixent. Now, there are low event rates, and there weren't any real clinical correlates in the majority of these patients, but there were numerically higher rates of these laboratory anomalies, and something we're going to be monitoring in the real world. This slide shows the safety profile in terms of just the overall and most common adverse events at week 16 and also at week 24. And here what we see is that, yes, there's a little bit of a higher rate of serious adverse events observed for Rinvoq at week 16 and at week 24. And interestingly, we see higher rates of acne in the Rinvoq arm. This is something that comes up really across the class of JAK inhibitors, although maybe a little bit more common, particularly within Rinvoq. And we don't see really any acne or much acne showing up for the Dupixent treated patients. On the flip side, we see markedly higher rates of conjunctivitis, those eye adverse events that come up with Dupixent, compared to in Rinvoq, where we really see very low rates of that. And overall, a similar safety profile observed out at week 24. Now, I should point out as well that there was one death observed in the Rinvoq 30 arm, and there were no deaths observed in the Dupixent arm. So to summarize all of that safety information, rates of serious adverse events and serious infections were higher for Rinvoq compared to Dupixent, although albeit a low event rate. Most frequent adverse events with Rinvoq were acne, and the most frequent adverse events for Dupixent were conjunctivitis. There were no cases of active tuberculosis, venous thromboembolism, major adverse cardiovascular events, or GI perforation in either group, and there was one death observed in a Rinvoq-treated patient. Now, there were cases of anemia, neutropenia, lymphopenia, and elevations in CPK levels for Rinvoq compared to Dupixent, and this is something that I will show you in a few slides how we're going to monitor for that. Now I'm going to take you through how can we properly initiate Rinvoq therapy in patients with moderate to severe atopic dermatitis. Ultimately, the choice of which one to use is yours to make with the patient. It's going to be part of that shared decision-making between the clinician and the patient. The recommended dose is with the one that you want to use. So you have a couple of different strategies for how you might go about this. You may say, you know what, I need to cool this patient off immediately. I'm going to, right out of the gate, I'm going to go straight to a 30 milligram dose. And then I continue them on therapy for as long as they need to be on therapy. An alternative approach would be to say, you know what, I'm going to actually start with the lower dose. I'll go with 15 milligrams and see how they do. If they do really well, great. And if not, I can always step them up to a higher dose of 30 milligrams. That's another approach that you can do. Ultimately, the choice is yours. So how do you make that decision? Well, there's a few things to think about as you make that decision. One, the 30 milligram dose was shown to be particularly impactful, particularly beneficial for patients with more severe disease. So if you have someone who's really severe, real, train wrecked, difficult, recalcitrant patient, that's where 30 milligrams really shows its value and differentiation above and beyond the excellent efficacy seen with the 15 milligram dose. The other thing to think about is whenever we're talking about chronic disease management, we always want to try to maintain patients on the lowest possible dose to maintain good long-term disease control, but not expose patients to more medication than they need to be exposed to. So you may start them off at 30 milligrams to shut down really severe disease, but once you do, you could even consider tapering down to a 15 milligram dose for maintenance purposes. That's left to your clinical discretion to do. You might even feel that the patient could take a drug holiday and could discontinue. That's particularly relevant for patients who have more intermittent disease or more seasonal disease, but don't need treatment all year long. So this is something that you can tailor to therapy. On the flip side, for patients ages 65 years or older, it is recommended to use the 15 milligram dose. One, because patients don't metabolize the medicines as well, but two, is they're more vulnerable potentially to some of the adverse events. And then on the other extreme of age, when we go to the adolescent age group, ages 12 to 17, there the recommended dose is 15 milligrams once daily for those who weigh at least 40 kilograms. Now, what about monitoring? So laboratory monitoring is going to be recommended when using Rinvoq. And there are certain labs that you want to check at baseline to make sure that there aren't any contraindications to starting Rinvoq or precautions to starting Rinvoq, as well as we'll do some monitoring. And the labs that we recommend testing are for looking at lymphocyte counts, neutrophil counts, and hemoglobin levels. This could be captured with one single complete blood count with differential, checking lipid levels, and also checking liver enzymes, which could be achieved with either liver function tests or comprehensive metabolic panel. The choice of when to monitor these on follow-up is a little bit variable depending on the recommendations. Some of these may be best checked at 1 month. Some of them may be best checked at 3 months. And so to simplify, it's written here as evaluate no later than 12 weeks after initiation. And then after that, you know, if everything is normal, you may not have to check them again at all, but you can certainly monitor as you feel is clinically necessary after that. And then at baseline, it's recommended just to do tuberculosis testing, check for viral hepatitis, just to make sure that there's no underlying disease that you're not aware of that might be a safety concern, and just check that afterwards, you know, as clinically indicated. Skin checks are recommended sort of as clinically indicated. I would argue we should be doing full body skin exams on all of our atopic dermatitis patients anyway to assess the extent of the disease. When we are doing that, we should also be doing, you know, just check to make sure that there's no undetected non-melanoma skin cancers that we should be monitoring or removing. And so that's something that we can also monitor. Certainly in the world of dermatology, we are very comfortable doing that. But with that, I conclude my presentation. I want to thank you for your kind attention, and I'll be happy to take your questions in the question and answer session later. Thank you very much.
Thank you. Thank you, Jonathan. Well, our last speaker will be Dr. Fatma Al-Breiki. Dr. Fatma Al-Breiki, she's a consultant dermatologist and chief dermatology division in Tuam Hospital in Al Ain. She is scientific committee of chairperson of Emirates Dermatology Society, previous chief of dermatology service in Al Ain Hospital and AHS Eastern Region Al Ain. She got fellowship in pediatric dermatology from South Africa. She is actively involved in teaching residents from different specialization. Dr. Fatma, she's interested in inflammatory skin disease such as atopic dermatitis, psoriasis, and she'll talk about RIMFOC, real-world cases. Dr. Fatma, the mic is yours.
Thank you. Good evening for everybody. Thank you, Dr. Ataibi, for your introduction. I'm very happy and glad to be between you. Thanks for all previous speakers for their great effort and great presentation. So let us go through real-world cases. We already heard a lot about atopic dermatitis burden, the mechanism of action of RIMFOC, the efficacy and safety data, and let us now see some real-world cases. So this presentation is sponsored by AbbVie, and these are my disclosures. And let us move to I have 4 cases, so let us move to the first case. This is a 32-year-old male who's known to have atopic dermatitis for many years. He failed on topical treatment and phototherapies for several months. He was highly affected by his condition. As you can see, his DLQI is quite high here, and his EASI score is high. But the worst part of his condition is his hands. So let us see the patient before the treatment. So you can see all these lichenification, fissures, and scales on the palms and on the dorsal aspect of his hands. But other areas also were affected. You can see the trunk was affected. Then you, by the way, the patient is applying calamine lotion here. If you see those white lesions here or the silvery scales lesion, this is not psoriasis. This is the calamine lotion that the patient is applying just to reduce the itch that is causing a problem for him. You can see that the extremities also was affected. So patient was started on RIMFOC after we already did the blood test, and patient was started with 30 milligram RIMFOC as I'm following the patient dosage here. He's an adult patient, so I started with 30 milligram, and you can see after a few weeks on being on RIMFOC, the dramatic change on his hands. So on the left side, you see before the treatment, And on the right side, you see after the treatment. Again, you can see before and after the treatment. And actually, I called this patient the second day after he was started on Rinvoq, just to ask him how he is doing with his itch. And he told me that there is a dramatic improvement on his itch. And as already Dr. Prof. Goderham mentioned in her presentation, that you can see a dramatic improvement in the itch from as early as day 2. So moving to other photos of this patient before and after, before and after. So patient is currently using only Rinvoq with emollients. He stopped using steroid. But what the patient told me on the last visit, that he started having acne. And he asked me, is this because the treatment? Yes, it was a mild acne and well controlled with a topical acne treatment. Moving to second case, this is a 17-year-old male who is living in a remote area. We are going to this remote area once. I actually go there once every 3 months. He has atopic dermatitis for many, many years since childhood. And he was usually using a high topical steroid, clobetazole, with no improvement noticed. Patient reported missing from the schools because of the sleep disturbances that he has. You can see his EASI score is high, and the patient and the family preferred an oral treatment over an injection. So before the treatment, this is the patient where you can see all these lichenifications on the extremities, upper and lower extremities. And because he's an adolescent patient, I started this patient on Rinvoq 15 milligram once daily. And you can see the dramatic improvement after a few weeks of being on Rinvoq, with well control of his condition, with only topical emollients and the Rinvoq. Moving to the third case. This is a 17-year-old female with severe atopic dermatitis who failed on phototherapy and cyclosporin after tried it for a few months. Then she was started on dupilumab in 2019 with a great improvement that lasts for a few years, but she started to deteriorate in August 2021, where she stopped the dupilumab as she thought that it is not helping her condition at all. So when I saw this patient, her EASI score was very high, and she was highly affected by her condition. And she was started on upadacitinib 15 milligram with great control of her condition. This is the patient before the treatment, where you see that upper extremities, lower extremities are highly affected with all these scales. Erythema, excoriation here and there, lichenification. And this is the trunk of this patient, where again you see all these excoriation, lichenification, erythema, maybe some sign of infection here and there. And after starting on Rinvoq, you see the remarkable improvement on her condition. So this is on the left before the treatment, and on the right after the treatment, before the treatment, and after the treatment. Actually, this patient, I was encouraging her to keep using her emollient regularly and topical steroid on the resistant area if there are any resistant area, but she is unfortunately not helping by using her emollient. She's using the emollient as whenever she thinks that she needs it. But one of the important things that we have to encourage our patients is to keep using their emollient in a regular basis. So this is before on the left side, and this is after a few weeks of being on the treatment with remarkable improvement before and after. So she's currently on Rinvoq, topical steroid, and emollient. Moving to the last case, This is a 48-year-old male who is known to have atopic dermatitis for 10 years, who failed on topical treatment, phototherapy. There was no improvement of the pruritus at all with the phototherapy. He was started on dupilumab with marked improvement of the itch. Then he started to relapse after only 6 months of being on dupilumab. It was not anymore helping his itch and the skin condition, so we decided to stop dupilumab. His EASI score was 30, his body surface area involvement was around 30%. Started on upadacitinib with a remarkable improvement in the itch. After only few days on Rinvoq, patient still on the topical treatment, but mostly on the emollient. So this is the patient before the treatment. You see the involvement of the trunk with all these excoriations and lichenification, the erythema here and there. Again, you can see the extremities, and there are some signs of infection, as you can see it here in vitiligo, but he has a lot of excoriated papules and lichenification here and there. So after treatment, and this patient was started on 30 milligram Rinvoq, you can see after only 2 weeks of being on upadacitinib, you can see that we already started to see a remarkable improvement on the patient's skin. Again, on the lower extremities, this is only after 2 weeks of upadacitinib, you can see a wonderful improvement on his skin. And this is after 1 month of being on upadacitinib, where you see that almost his skin is clear. And this is after 1 month of being on upadacitinib. So, in conclusion, Rinvoq showed rapid onset of action for itch reduction. Rinvoq resulted in rapid discontinuation of topical corticosteroid with high levels of skin clearance in most of those patients. And Rinvoq rapidly and significantly improves patient-reported symptoms and sleep in patients with moderate to severe atopic dermatitis. Thank you.
For Dr. Atlal, she talked about atopic dermatitis disease burden and unmet needs. Or for Dr. Mohammed Lanizi, he talked about atopic dermatitis and Rinvoq mechanism of action. Or for Professor Melinda, she talked about efficacy or safety. And Professor Jonathan, he talked about new frontier of atopic dermatitis management. So please, any question, feel free. Dr. Shab.
I would like to thank you all for these nice presentations, which will really cover, atopic dermatitis, and also spoke about, the new medication approved for the treatment of atopic dermatitis, Rinvoq, upadacitinib. I have a question to Dr. Melinda. When she discussed, side effects of Rinvoq, there was something that she did not comment on, or I was not really concentrating. One of the side effects, atopic dermatitis, it was mentioned. So does it cause exacerbation of atopic dermatitis in some patient? Just we need to hear your opinion about that.
Thank you, Dr. Shab. Prof. Melinda?
They're always, when you're doing a clinical trial, if it's how the investigators report it. So if someone might be having a suboptimal response and they, because it is such a heterogeneous disorder, if they're having a bit of a flare up, you would report that as atopic dermatitis. So it's not so much, I don't think there was, we'd have to look at patient level data to say, is it worsening from baseline, or were they just really that much better and they were having a bit of a flare up at the time? So I think we see that in a lot of atopic dermatitis studies where you see this and it's always listed as dermatitis atopic based on the MEDRA coding, but I don't think there were really cases where patients were worse than baseline.
I'm asking these questions because, you know, Raptiva, when it was first introduced to treat psoriasis, it can cause severe exacerbation of psoriasis in certain patients, and it was, you know, stopped because of that. This is why it's very important to, you know, clarify it to us. Thank you.
No, that's a great point.
Thank you, Dr. Shab. Any question? Dr. Hussein?
Assalamu alaikum. Thank you, Dr. Melinda, and all speakers. My question about how long the patient can stay on the drug, and what about the safety of the drug if he used it for a long time, more than 1 year? Second point, if he missed 1 or 2 doses, and he missed taking the drug for 2-3 days, what he has to do after that? Thanks.
I'll take that one. So for long-term, you know, we don't have a randomized withdrawal retreatment study here, but we can look at the phase 2 study where patients did come off therapy, if you're talking about upadacitinib. And so there was a variable amount of time that patients flared, but there was a recurrence of their disease once they were off therapy. But then when they were retreated, they had an improvement again. So that's with upadacitinib. That's from the phase 2. If we look at various JAK inhibitors in phase 3, we have the JADE regimen study with abrocitinib, which, you know, I'm not trying to say upadacitinib is the same, but just in general with JAK inhibition, they treated patients with the higher dose for 16 weeks, and then they kept some patients on the high dose, some went to the low dose, and some went to placebo. And I believe it was about, and then they looked at the flares off of disease, and patients who went to placebo had the highest chance of having a flare off of disease, but not every patient. There was a small proportion of patients who did not flare, but the majority flared once they were on placebo. With the 100 milligram, some were able to maintain their improvement with the lower dose. Some patients flared. And I think that really goes back to the earlier lecture about the different types of disease. So if you have somebody with episodic disease and you treat that episode, they may have a period of control. Whereas other patients who have continuous severe disease, when you try to take the medication off, they will have a higher risk of flaring. So I don't typically take patients off therapy unless there's a specific reason. As far as the long-term efficacy, we are gathering that, and we'll have 5 years of efficacy data from the long-term extension, but that will take time. We can sort of look at the rheumatoid arthritis population program who are further ahead. And as far as, you know, their data goes, nothing new has come up. But again, they continue to monitor their population. We continue to monitor our population.
Thank you, Melinda. Any question? Dr. Atlal, I ask about which is the common comorbidity with atopic dermatitis? Comorbidity with atopic dermatitis.
Comorbid conditions. Huh? Anna? I have bad luck with your mics tonight. If you are asking about the comorbid conditions, the classical comorbid conditions are the atopic conditions related to atopic dermatitis, which is the usual scenario. So patients with atopic dermatitis will ask about other atopic conditions. And other comorbid diseases that share the same pathophysiology of type 2 inflammatory disorders. So we are more broadening now our view in terms of atopic dermatitis, that it may be related to other autoimmune disorders like ulcerative colitis, rheumatoid arthritis, other respiratory problems that share the same pathophysiology. And also we are looking into the patient's weight, as Professor Melinda, she mentioned, even the dosing scheduling is escalated sometimes in patients having body mass index, higher body mass index. So yes, there are other comorbidities related to the metabolic syndrome. We have also to be very cautious about it, like in psoriasis, so atopic dermatitis, we should more broaden our view in terms of other comorbidities.
Thank you. Any question? Prof. Melinda, I want to ask you, what is your baseline management before you start Rinvoq, and what is the most common side effect of Rinvoq?
Great question. So we kind of have a standard workup that we've been doing for years for our patients on TNF inhibitors or cyclosporin. So we have like a little package already prepared with a lab work requisition, with a TB test requisition. All of that is, the same workup that we've been doing already for so many years. So it didn't really take much change in my practice. The only difference now is checking in on their Shingrix vaccination status. It was over 50, but now the recommendation's been updated for 18 and above if they're having some immunosuppression. So, in addition to our package, we also work with the patient support program to try and get them the Shingrix vaccination. With the most common adverse event, if you look at the trials, it says acne, and I have seen acne, but it's really not that common. And some people may just be getting a few papules. And as an investigator, when patients came and you asked them, and they might show you 2 papules on their back, and you had to record that as acne. So, you will find some if you look for it, but to me, it was not a major deterrent for treatment. I think only 2 patients dropped out of the Measure Up 1 or Measure Up 2 because of acne. So it's just really something that can be managed topically and something to be aware of.
Thank you. Dr. Mohammed.
I have a comment regarding Dr. Shihab's question. Dr. Melinda, do you think the exacerbation of atopic dermatitis, it might be that because we use systemic treatment for atopic dermatitis many times, and sometimes you get non-specific eruption with, for example, dupilumab, that could be psoriasiform or eczematous, that is usually transient and goes away with continuing treatments. So that's a possibility, I guess. Once you block the cytokines, you might have other cytokines who can take over and produce, for example, a psoriasiform eruption. The other possibility, is it possible because of the secondary infection? Because we know that atopic dermatitis sometimes can be exacerbated by secondary infection, and using an immunosuppressive medication might make it worse. Do you think this is a possibility in that or not?
Yeah, for sure. Actually, I was just dealing with a case this morning of a patient calling thinking, she'd had tinea versicolor in the past, and it was really hard to tell, was this her AD flaring up? She did have scraping for malassezia. So there are, sometimes you clear them up and you see the molluscum lesions that were responsible for the flare. So I do sort of go through that in my mindset when a patient comes with a flare that are on good therapy, like what am I missing? What infection is there? Or what contact? Do they have a contact dermatitis as well? If they used a new bubble bath or shower gel or something that you have to consider, but you do see these flare-ups with all treatments, and I agree with you that we need to consider what is underlying this. What is the cause of this flare? Sometimes patients will tell you it's stress, but honestly, I don't know that stress alone can cause a lot of these flare-ups that we see, and I think infection is probably top of the list.
Can I ask Prof. Gooderham a question, please?
Yes, please.
Prof, we used to see a lot of cases of psoriasis with dupilumab. Now, after some time of being treated with dupilumab, do you have any cases with Rinvoq that developed psoriasis?
I have not. I'm just thinking, you know, I'm in a dermatology sort of chat group where we share difficult cases, and there have been some really interesting dupilumab cases with clear psoriasis, like very well demarcated lesions. I haven't seen it with JAK inhibition yet, and probably because we have a wider blockade of cytokines that we might not get the same tipping of the balance as we do with monoclonal antibodies that are very targeted. But,
so how you treat those patients if they got psoriasis with dupilumab? What do you do?
I've had patients that actually switched to a psoriasis biologic, like an IL-23 inhibitor, with good success a couple of times, but those were the couple of severe patients that I've had. For the most part, I've been able to manage with topical therapy, but I've just had the two that I've switched biologics, and then I'm waiting to see if I need to switch them back at some point. And because then you question your own diagnosis, you know, was this psoriasis all along with something else going on? And so sometimes it's a bit of trial and error.
And another question, please. Those adolescents who have a very high weight, I have an adolescent who weigh like 100 kilo. Do you think the right decision to take here to give them Rinvoq 15 milligram only?
You know, when you look at the data, a 30 milligram dose is higher, but it's not like double a 15. So I've had some great success with just 15. I would first start with 15 and see how it goes. And then if you're not having the response, then consider up dosing sort of off label if necessary, what's needed to treat the patient. But honestly, the 15 milligrams is so impressive. You don't need 30 milligrams a lot of the times, because 15 can get most people where you want to get them.
Thank you. Any question? Well, because of short of the time, Professor Goldman, I have a question for you. Do any condition use like off-label, like nodular prurigo with Rinvoq?
I haven't used it in that before. I know others who have. I just haven't had a patient lately that needed it, because I had a couple that I'd already put on dupilumab. As was already pointed out with the hand dermatitis, I've had some hand dermatitis, and then I've had some other off-label conditions, generalized granuloma annulare, which has failed everything else, has had some really nice clearance with Rinvoq. And I'm just trying to think if there's anything else that I've used. I think that's about it. We've only had it since October, so I think that's about all I've used it in.
Yeah. Dr. Fatma, the question is for you also.
Sorry, can you tell me the question?
Yes.
Off-label.
Off-label, no.
Yes.
You know that dupilumab is studied now in prurigo nodularis, and they have few cases with a great results with dupilumab, but with Rinvoq, no, not yet. I don't know if there is any study going on, but I don't think so. So I don't have any patients on Rinvoq with prurigo nodularis.
Thank you. Any take-home message from you, our speaker? Dr. Atlal, we start with you. Any take-home message for our audience tonight?
Actually, we are happy and glad to have different treatment options when it comes to atopic dermatitis, especially for the past years, we were having limited options. We are looking forward to have more targeted therapies, more effective therapies, and at the same time should be a safer medication on the long term. So it's nice to attend and hear from the experts, hear from Professor Melinda, and hear from the experience of Dr. Fatma Al-Breki. Would like to take the opportunity to thank them and thank AbbVie for giving us this opportunity. Thank you all.
Thank you. Dr. Mohammed? Dr. Fatma, any take-home message?
Rinvoq is one of the good treatment. You can see a fast results, and this is what most of our patients is looking to have. I think one of the important objective is fast improvement in the itch, one of the very common burdensome that is associated with atopic dermatitis. So it's a medication that really works fast with the great results and makes a very big improvement in the quality of the life of the patient. So consider this treatment, try to start using it now. In adolescents and in adults, I don't know if we'll have any studies in the children, because I also see bulk of children who suffer also from atopic dermatitis. So please keep the best of the treatment for your patient from the beginning. Start with the right treatment from the beginning. Don't delay the right treatment till your patient got fed up and leave your clinic. Thank you.
Thank you. Prof. Melinda?
Yeah, I mean, not much to add to that. That's been really said. I guess one of the things I would just add on that is that I've really had such great experience in those patients who either became refractory to dupilumab or were suffering from some of the adverse effects like conjunctivitis or head and neck erythema, that we tried everything to help, and nothing was working. Once I switched them to upadacitinib, they were amazed. And so you do hear some words from your patients like a miracle, it was amazing, it was unbelievable. So it's really great to hear that feedback from your patients, and that you're able to offer them something new that didn't have the side effects that they had been dealing with.
Thank you. So at the end, we like to thank our host tonight, Afi, and also, as you know, Rinvoq, it is rapid lasting, superior experience, and more than 10,500 people they are use it, and it's approved more than 12 years of age for moderate to severe atopic dermatitis. At the end, we like to thank our distinguished speaker, Dr. Atal Lafi, she's chairman and the head of council of dermatology, Ministry of Health in Kuwait. Dr. Hamad Anizi, he's our chair faculty of dermatology in the KIMS, and Dr. Fatma Breaki, consultant in Al Ain Twam Hospital, and Professor Melinda. It's our pleasure to have you tonight, and we hope to see you, inshallah, soon. Take care and good night. Ma'as salam.
Thank you.